Yeah, it's a pretty color. All right, good morning. It is 9 a.m. We'll go ahead and get started. So between the last class and this one, you guys had chapter 7, and it's another skills chapter. I'll go ahead, and I know that I think it's cold. Everybody's running slow today. I'm just going to go through all these names. Let me know if you've got it done, what your score was. Brianna, Natalie, Katie, Cody, Thanya. Thanya, do you happen to have 2, 5, and 6?
Yeah, it is 100.
Okay, thank you. And I'll just skip special.
85.
Do you have, I need 2 through 6 from you.
This one, I got a 70. What was the other B?
Well, I need 182, 183, 184, and 185.
100 on 82.
Okay.
You say 83?
Yep.
83. I didn't do the bottom half, so.
Okay. 84.
The other one's 90.
Okay. Thank you. All right. Any questions on what we've gone over so far? Any questions? Did anybody catch the game show yesterday? Did you?
Yeah.
Okay. Was it helpful?
Yeah, it was.
Okay.
But I felt like it was like too few. I thought it would be like more than an hour, but I was like.
Yeah, I have 45 minutes because unfortunately, there's a lot of schools that watch it. So I can't have it go beyond 45 minutes because of class periods. So, yeah, we only do 15, but we've been doing it now for 2 years. So if you go watch the playlist, I have over 50. I think I've got like 62 of them. Each one has 15 questions. So there are literally thousands of questions on that playlist for you. Okay. All right. How do we know what to do with each patient? We follow the care plan. It's the care plan, the whole care plan, and nothing but the care plan. While we're following the care plan, we're going to observe for any abnormalities, and we'll always report those to the nurse. Every skill starts with the opening. Every opening starts with a knock. Then we're going to greet the resident, address them by name, introduce ourselves by name and title, describe the skill, get permission, close the curtain, wash our hands, and get our supplies. Big rule here, don't touch the patient until your hands are clean. These cards, what you see here, are actually in the flashcard deck with the blanks. So what you see on the screen is in that flashcard deck. You should be able to look at this card and answer, fill in all of those blanks by this point in the class. If you can't, you need to do this for yourself so that you know these rules. Okay, if we use or if we're going to be working around wet body openings, personal skin, or non-intact skin, we need some gloves. If we're going to wear gloves, the first thing they should touch is the patient. Good. Once you've touched the patient, be careful of what you're touching in your surroundings. And then if you wear gloves, you've got to remove them correctly, which is pinching up at the base of the palm and then going under with your other hand. Good morning. Barrier rules. If we're going to use supplies, we need a clean place to put them. And that's all a barrier is. It provides a clean place for our clean supplies. You can only touch supplies with clean hands, and you don't want those supplies to touch your uniform to keep them clean. Barrier is all about clean. Everything is about, with the barrier, it's about clean. In order to do that, you want to go get the barrier first, spread it out on your surface, whether it's the table or the floor, and then go get the rest of your supplies. That way it keeps you from holding those supplies against your uniform. Sometimes we're going to need a privacy blanket anytime the patient is uncovered or undressed, and it's there to provide warmth and privacy. Privacy curtain does not provide warmth. Keep that in mind. When we're putting it on, we don't snap it or shake it. We lay it out over the sheet, pull the sheet down underneath. And if we are wearing gloves, we take those gloves off before we take the privacy blanket off So we're not touching that sheet with his soiled gloves right up next to the face. Linen rolls. We've heard all of these or most of these before. You have to have clean hands to get your linens. Your linens can't touch the uniform. We don't snap or shake them. Clean rolls toward me, dirty rolls away. Don't let anything touch the floor, whether it's clean or dirty. And anything you take and don't use has to be discarded, not saved for later, and certainly never put back on our clean supply shelf. No, we're going to discard it, put it in dirty linen. So nothing, treat this like an ATM machine. You can take out, you just can't put back in. Okay. Right, because this is used by everybody, all patients. We don't want that patient's cooties in this environment. Okay, good. I like the cootie analogy because it's something that you can kind of envision, right? All right. Patient must always be in the middle of the bed. We don't have side rails to keep our patients safe in all settings. In fact, side rails are a restraint. They require a doctor's order. So we have to be able to keep our patients safe without side rails. And to do that, just keep them in the middle of the bed at all times. If we are going to move the patient, we're going to scoot them toward us and then roll them away. If they're going to move, just ask them to flip over and they will align themselves in the middle of the bed. They won't be comfortable hanging over the edge. So just ask them to turn if they can do that on their own. If we're going to do it, scoot toward me and then roll away. We always turn a patient away so we remain behind their behind. Patient must always be in the middle of the bed. That's our cardinal rule there. So at the end of the skill, if you've moved that patient in any way, at the end of the skill, I want you to take a moment to look at your patient. Look closely. Are they too close to the edge of the bed? Do they look comfortable? So remember, the test is all about the patient. It's not about you. That evaluator is not paying attention to you as much as what you're doing to the patient. And if you can make that change in your mind, if you can start focusing on the patient rather than you and what you're doing, you will pass the test with 100% because that's where the checkpoints are focused, is on the patient, not on you. Does that make sense? Okay. It's a hard switch to make because you're being graded and you know that in the back of your mind, you're like, this is, do or die. I've got to pass this test to get certified, to get working. And, you will put that pressure on yourself. But that's not really what the grading is all about. The grading is all about, okay, when you get certified and you go out there and you're working with grandma out wherever, how are you going to treat grandma? Yeah, so that's what the test is all about. It's not about right here, right now, making sure that every little technical detail is right. That's not what this is. This is, okay, when you're out there and we're not watching, what are you going to be doing? That's what the test is all about. And if we can make that kind of switch in our mind, the test becomes super easy because you would never leave a patient laying in the bed completely exposed. You would never have the patient right up next to the edge of the bed where they could fall off. You start paying attention to those details because you're paying attention to the patient. Does that make sense? Yeah. Just a little helpful hint for the state exam. I have a whole video on that, by the way. The test isn't about you. It is. It's about the patient. Now, the students that have listened to me say that, you'll send me an email or a text message or something when you pass the test and you'll say, hey, I passed. And I'll say, congratulations, it's great. But then I'm going to ask you, was it as bad as you expected? And every student that has made that switch said, oh no, it was super easy. It was super easy. Yeah, so I can congratulate you. Yeah, it's not nearly as hard as you think it's going to be. It really isn't. It's not about being super, super technical. It's just about treating our patients like people. Just treat them like people, real people, even if they're plastic. Real people, yeah. Yeah. If you've noticed, as we've gone through this, I know we still have a couple more to go, but as we've gone through this, if you've noticed, it's all common sense. This is all stuff you know. I mean, other than a few small things like clean rolls toward me, dirty rolls away, you know, some small things in there.
Like the specific stuff, like how you're moving the patient. That's probably the most difficult thing because you don't know, like.
Right. Yeah. If you didn't know furthest arm up, closest arm crosses, closest knee bent, furthest knee angled, you would just try to like, push that patient over. And that's harder. You can do it, but it's harder. So I'm teaching you strategies just to make your job a little easier, right? And to keep the patient safer. But none of this is like rocket science, earth shattering stuff, is it? Now we're going to get into some things that are a little more technical today, just a little bit, but I want to bring to your attention that everything that we've learned so far on the principles, I'm not talking about the skills, the principles, it's all stuff you pretty much know, right? So going to the next principle, washing rules. Yeah, you won't, whatever you wash, you rinse, whatever you rinse, you dry. I mean, that's like a no-brainer. Now, what you probably learned in this is that we don't add soap to the basin, and you probably would have, you'd get a big basin of water, you put some soap in there, suds it all up really good. But the problem with that is now we can't rinse. So then we have to go get a second basin, and now we got to clean two things, and it's an extra cost for the patient. And it's just a whole bunch of problems there, right? So you learned that we don't add soap to the basin. We put soap on the washcloth. And now you're going like light bulb moment. Well, yeah, that makes sense, right? So when we get water for the patient, we use a paper towel to turn that faucet on because our hands are clean and the faucet is not. We check the water. It should feel warm, not hot, not cold, just warm. Who else has to check that water? But why? Yeah, make sure exactly. So again, it's all about the patient. It's not about you hitting a technical point. It's about the patient, right? So we're going to ask the patient to check the water temperature. If we're washing a wet body opening, eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions, we're going to use that leaves method and we're going to learn that or use that again today. If the skill takes a long time and the water gets cold, or if we accidentally put soapy washcloths back in it, we're going to change that water out so that we always have clean water and warm water to rinse with. Try not to get your surface wet. So we're going to protect the table with a barrier or the floor if we're doing foot care. We're going to protect the bedding with a towel. Now, I want to kind of time out there for a second because I got a question in my YouTube channel the other day. Why can't you just use a barrier on the bed? You put a barrier on the table. Why can't we put a barrier on the bed? And you can. There's nothing wrong with it. There's no checkpoint that says you can't. It just says to protect the sheets from getting wet, and that's fine. But barriers are they're waterproof. Yes, they got that waterproof layer, but they're not as comfortable to lay on because they get kind of sticky. It's better to use a towel for bathing because that's what we normally use. Now, when we get to Peri-Care today, we are going to use a barrier under the patient because we're not just worried about bath water. Patient is incontinent, so we have to worry about urine, and urine will soak through the towel and onto the sheets. That's not a good idea. So we do want something more waterproof under the patient when we're cleaning them for Peri-Care. Make sense? Okay, so on the bed, you can use a barrier if you want to, knock yourself out. I prefer a towel. It's a little bit more natural for the patient. But for Peri-Care, we're going to use a barrier. All right. And if we're going to use lotion anywhere, we're going to warm it up and then wipe off the excess. All basins are cleaned the same way. For the test, rinse it, dry it, store it. They don't care how. There's no testing checkpoint that governs this. Rinse it, dry it, put it away. They don't care. I care because I don't want you to cross-contaminate and then later bring those pathogens back to the patient. So we're going to rinse the basin, set it down, pick it up with a paper towel before we dry it. Dry the inside, throw that away. Dry the outside, throw that away. And then this is the part that I care about. Get a paper towel to open that drawer. because the next skill that you do, you're going to be touching that drawer with your clean hands. So we don't want to go out of our way to contaminate that drawer. So if you don't do anything else, if you just rinse, dry, and store and you don't pay attention to any of the steps, that's fine. That's fine. But please use a paper towel when you open the drawer. That's the really big thing that we want to prevent. Okay. Now, we also learned shoe rules. This is something that we learned last class. And if the patient's feet hit the floor, we got to talk about their shoes. Slipper socks are not enough. Slipper socks don't protect against slips very well. They don't protect against sharps at all. And they certainly don't protect against pathogens. So slipper socks are just not a good idea. Shoes are the best idea. If you put a gait belt on, you place it on around the patient's waist over their clothing. Why that's a checkpoint, I don't know. But somewhere along the line, somebody has been putting this on bare skin. Don't do that. We're going to check it. You should be able to fit 4 fingers between the belt and the patient. No more, no less, just 4 fingers. Once you get it secured, you're going to use proper body mechanics to lift the patient. Their feet have to be flat on the floor. You're going to count before you lift them to make them a partner. So feet flat on the floor, 1, 2, 3. We're going to stand. We're using proper body mechanics. And then once they're standing, we got to find out, are you dizzy? You feel okay? Everything good? We want to know when we're at the chair, not down the hall. Once we are done with the walk and we return the patient to the chair, they have to be able to feel that chair behind them before you sit them down. And then every skill ends with the closing. So we want to make sure the patient is in a clean and safe environment. Bed is in the low position. We're going to ask them about comfort. We're going to offer them a magazine, make sure they're covered, adjust the head of the bed if requested. Close or open the privacy curtain, give them their call light. I don't care how you do all that. Just do it. Just do it all. So in my mind, it's comfort, curtain, call light, clean. That's how I remember it. Comfort, curtain, call light, clean. It doesn't really matter how you do that. Once you've done all that, though, you do have to go clean those cooties off. So we're going to go wash our hands. Now, if we're going to document, we wash our hands, then document, and then we're going to wash our hands again to wash off any pathogens we might have picked up from that pen. Good. So those are all the principles. You should be able to recite these by yourself now in your sleep. You've heard them every single class, and you're going to hear them again on Monday. That'll be our last review. Although Mondays, I go way faster. All right. So now let's review our skills. Now, this is where it does get a little more technical. This is where you probably did learn a few things that are not as immediately apparent to you. Okay. So a pulse is the measurement of how many times the heart beat over 1 minute. We're going to count as long as care plan tells us to. So if the care plan tells us 1 minute, we're going to count for 1 minute. But if the care plan doesn't specify, we can count for 15 seconds and multiply that by 4. The care plan for the test is going to say 1 minute. Heads up, count for 1 minute. Normal is between 60 and 100. That's what we're hoping for. Now, for the test, you probably aren't going to get normal because the person that's playing the patient is getting ready to test or has just tested. What do you think their pulse rate might be? Yeah, a little elevated. They're a little stressed. So don't be surprised if the pulse rate's a little bit higher for the test. We have to remember, what is our patient, whoever's playing the patient, what are they going through right now? But your patient in an emergency situation will probably have a higher pulse rate as well. Okay. What do we do with abnormals? Yeah, do we get to decide whether we're going to tell them? No, we're just going to tell them. All right. We're going to use 2 fingers. And if you use the fingertips rather than the flat part, they're much more sensitive. The radial pulse, which is what we're going to be told to take, is located at the top of the thumb side of the wrist. So if you put your finger on your thumb and you pull it down just to where your lines are, you know, your bendy lines of your wrist, don't come down here. You're not going to be able to feel the pulse very well through that tissue. So from the thumb down to the lines, 2 fingers, thumb on the back. Thumb on the back, super important, guys. You'll lose the pulse if you don't put your thumb on the back. You will lose it. And then you're going to count the thumps that you feel. Now, the evaluators on the other side of the patient, they're also counting. So you're going to have to say start when you start counting. You're going to have to say stop when you stop counting. That way they know how long you counted and that they can count for the same time and try to get the same number. You can be off by 4 beats in either direction and still be accurate. This is a documentation skill. In Florida, if you have 2 evaluators, we don't always have 2 evaluators. There's a nursing shortage where, you know, you may or may not, depends on who shows up that day. If you have 2 evaluators, then you're going to have to count with both of them, and they're going to tell you that. You're allowed to write down that first reading so you don't have to remember it. Okay, good, good. We learned how to dress a resident with a weak arm. Now, this is going all the way back to class 1. I know this was a long time ago in your minds because I've shoved so much information in your brains with each class. You're looking at this going, yeah, I know we learned it, but what do I need to know? So that's why I do these reviews, because as I shove more in your head, the stuff that we learned 2 weeks ago is going to get a little murkier, okay? So when we're dressing a resident with a weak arm, we want to ask them what they want to wear. Patients have the right to choose their own clothing. Don't forget that step. Super important. Our care plan tells us long sleeve, button or snap front shirt, pants, and socks. That's fine. But we don't get to pick off of the supply shelf which long sleeve shirt and pants. Patients have the right to choose. You're going to get the clothing before you undress them. Again, look at your patient. If they're naked, something went wrong. Okay? Something went totally wrong. So we're going to get our clothing before we undress the patient to minimize exposure. You should also use a privacy blanket. Again, if you look at your patient and they're naked, something went wrong.
So in the pre-bathing, we did remove our clothes and remove their shirt off and then wipe their upper body in the front. So we gotta get them naked first and then wipe them off and then.
Right, but we're going to keep them covered with a privacy blanket.
Okay.
Yeah,
Okay.
and that's really what that blanket is all about. Again, your brain should trigger. If my patient is naked, I took a wrong turn. So I got to cover that patient up somehow. Clothing, blanket, sheet, towel, something. Right. Yeah. Yeah. It's like, excuse me. Yes, absolutely. Absolutely. I mean, how comfortable would you be? And let me, for the ladies in here, we don't have any gentlemen right now, but for the ladies in here, how comfortable would you be going to a female gynecological appointment, having them strip you completely naked and put you on that table? Yeah, we're all like, no. Those little paper things don't cover much, but I'll take it.
Yeah.
Right? Better than nothing, right? That's why they use those little paper things. It's not for them. Who's it for? You, the patient. Same thing here. If you look at that patient and you're seeing things that are normally covered by a little paper thing at the gynecological office, you took a wrong turn. Good. We just don't use paper. That's the only difference here. Also, let's go back to thinking about, us at the gynecological office, right? Let's go back to thinking about that. How awkward would it be if they're doing an exam on you completely silent? Oh yeah, that would be like super duper awkward.
I'm gonna be asking questions like, please talk to me. What's wrong?
Exactly. I mean, talk to me about the latest movie, the Super Bowl coming up. I mean, something, anything. And that's actually part of training for these physicians and nurse practitioners is how to carry on surface level conversations while you're performing sensitive exams. Yeah, absolutely. So we have to remember that when we're working with patients and their very private areas, and we're going to get into Peri-Care today, and that's going to be super important. Now, up until now, we have focused our conversation on kind of reciting the steps out loud, right? I'm going to, put the privacy blanket on you. I'm going to remove your gown. I'm going to clean your face. We're kind of reciting our steps, and that helps you remember what to do. It helps your patient because you're not silent. But we should start to think beyond that at this point. And we're going to learn feeding today. And feeding, we cannot recite steps, because how weird would it be if you had to be fed and somebody said, okay, I'm going to get some food on the spoon and I'm going to bring it to your mouth. I mean, that's very condescending. We're not going to do that. Does that make sense? So up until now, we've kind of focused our conversations on what we're doing. We need to start making that transition over from us to the patient. Okay, good. The way that I teach these skills, the order that I teach them in is not random, by the way. I don't know if you've noticed that. It seems like we're kind of jumping around, right? We did pulse one day and a week later we do respirations. We do one range of motion and then a week later we do another. It seems like, why wouldn't you just do all the range of motions together at one time? Well, I teach them in a very specific order because it helps with your retention. It also helps with being able to review the material multiple times. So and we're going to build, right? So if you've noticed, every skill that we've learned, we've built on something we've already learned. And that's why when we get to class 6, which is where we are today, we should be starting to shift our focus onto the patient by this point. Okay. So just like you don't realize just how scientific the test actually is, you don't really realize why I'm leading you in a certain way. But this method that I've developed works. It works very well. And you guys will have no trouble on the state exam. But more importantly, much more importantly, it doesn't do you any good at all, no good, to pass a state exam, but have no idea how to operate in a clinical setting. Can you imagine taking a 2-day test prep course? They kind of show you the skills and that's it. That's it. Nothing else. They just show you the skills and that's it. And you get to the test because you've watched a million videos and you kind of fumble your way through it and you don't do great, but you passed. Congratulations, you're a CNA. Now you start putting in applications because you need a job. And you get on to the first day at work and you're like, I really don't know anything. How stressful would that be? The problem is that about roughly 60% of CNAs that are hired in a setting leave that setting within the first 3 months. Yep. Because you weren't properly prepared for the workplace. It's not enough to pass the test. You've got to be prepared for the workplace as well, right? Does that make sense? That's why I teach you the way I do. I don't want you to be in that 60%. I want you to be confident and successful. All right. So we're going to get our clothing before we undress them. We lift from below, supporting the joints as we lift. We don't overextend or force movement. We're going to undress the strong arm first, dress the weak arm first, adjust the clothing for neatness and appearance. Make sure everything is lined up properly. Put the gown in the hamper. Don't leave it on the bed or on the table. That's something that's missed quite a bit on the state exam. And put the call light in the stronger hand. We learned how to do hand and nail care. Speaking of hands, this is a mini mani. We're going to soak the hand, wash the hand, rinse the hand, and dry the hand using our washing rules. Okay. So soak, wash, rinse, dry. When the hand is being moved, provide support. When the hand is out of the basin, put it on something soft. We're going to clean under the nails with the beveled end of the orange stick, wiping it off in between nails. We're going to file in one direction to get rid of any sharp edges. And then we're going to apply lotion last by warming it up and wiping it off. Good? All right. We learned how to make an occupied bed. So when we make an occupied bed, this is all about changing the bottom sheet. Really, the top sheet, the pillowcase, that's just making a bed. I mean, there's nothing special there. But the bottom sheet is what is difficult with somebody in the bed. So we're just going to change that bottom sheet a half at a time. We're going to loosen the corners, roll dirty toward the patient. Put the new sheet on, smooth it out, fasten the corners, roll the clean one toward me. Tuck the clean under the dirty, put them back on their back, go over to the other side of the bed, do it all again. Remove that old sheet, smooth out the new one, minimize wrinkles. Put the top sheet on, get the corners under the mattress. I don't care how you do it. Hospital corners are best. Try it out. It's not that hard. And then we're going to change the pillowcase, limiting the amount of time that patient is without their pillow. Opening should face away from the door. It's not a graded checkpoint, though. Okay. Keep your patient covered. Remember, if you look at that patient and they are uncovered and you see their knobby knees, should you be seeing knobby knees? Keep them covered. Okay. All right. Side lying position. This is turning somebody over using some pillows to prop them there. Honestly, these two are my favorite skills. Making an occupied bed, because it's a Houdini skill. You can actually make money at parties with it. And side lying position, because if you can get somebody to do this to you at home, it's the best sleep you will ever have, because you are fully supported. And it's what we call an anti-gravity. You know those gravity chairs that were really popular a couple years ago? You know, you'd kind of sit back and it just kind of, yeah, those. This does that for you. It removes all areas of gravity stress, because that top leg is supported, that top arm is supported, the back is supported. So if you can get somebody to do this, man, it is a beautiful sleep. All right. So we're going to, in order to turn somebody with minimal stress on them and you, furthest arm over, closest arm crosses, closest knee is bent, furthest knee is angled. And then just hand on the shoulder and hip, and you roll them on their side. Super easy. No manhandling involved here. Then we're going to put a pillow behind their back to keep them on their side. So you lay the pillow there, tuck the first edge under the patient's back as far under them as you can get it. The further, the better. Then you roll the edge that's closest to you, roll it up and over, and tuck it under the patient too. So after that roll is tucked, it forms a very nice tight roll. Now here's a cheat for the test. When you tuck that pillow, if it's not tightly tucked, if it's kind of floppy and it looks like the patient, it's going to pop out from under the patient, just roll the patient back onto the pillow a little bit. Put your hand on their hip and shoulder, roll them back onto that pillow a little bit, and it'll hold that pillow in place. So there's a cheat for the test. But understand that in a clinical setting, if you don't get that pillow in a good tight roll, even if you roll them back onto their back a little bit, when you leave, that pillow is going to pop out and they will end up on their back. And now we haven't accomplished what we needed to accomplish. Okay. So it's a good cheat for the test, but in a clinical setting, please remember that we really want to make sure that pillow is doing a lot of work. Okay. Then we're going to go around the bed, lift that top leg, put the pillow between the knee and the ankle. So that pillow should be long ways between the knee and the ankle, and the top leg should be just a little offset. The third pillow goes underneath that top arm. Get it supported. Then we're going to adjust the pillow under the head and neck and put the call light in the bottom hand.
So we're going to first put them towards us, and we're going to
Right. And then roll them.
Okay.
Because after the roll, where do they need to be? In the middle of the bed. If you take a look, if you do that, you ask them to scoot towards you. They scoot. You do all your positioning, arm up, arm over, leg bent, leg angled, and you roll them, and you see that they're this far from the edge of the bed. Because they might be a little bit bigger person, right? So they're this far from the edge of the bed. Should you ignore that?
No.
No, we're going to roll them back on their back, scoot them closer to you, do it all again. Don't assume that the evaluator didn't notice. I guarantee you they did. I can tell you now, all of my attention has been on you guys so far today, right? She is too close to the edge of the bed. Did anybody notice that? She is not in the middle of the bed. Yeah. So I bring that to your attention. I didn't do that. Whoever practiced last left her in that position. That's okay. But I bring that to your attention because as a nurse, I assess like I breathe. I made that observation without even being aware that I made that observation, and it's bothering me. I want her in the middle of the bed. Okay, so don't think that those evaluators don't see something. They do. They assess like they breathe. It's involuntary. It's automatic. We spend 3 years in school. That is what nursing school is, assessment. Assessment. 3 years of assessment. So we are very well trained in assessing. Okay.
But you said if after the skill, we should step back and look at the patient, and if we notice they're not in the right position, then we should
Yeah. If I were ending my skill and my patient is like this, right? And I look at them and I've already given them their call light. I've already opened the curtain and I take my step back and I look at them and I read the care plan and I'm like, yeah, she's a little too close to the edge of the bed. I would just push her to the middle of the bed or ask her if she's a live person, can you scoot to the middle of the bed? Mannequins don't scoot on their own. You kind of have to move them. So address it and then go wash your hands. Now, if you have done your whole closing, thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Your environment's clean, bed is in a low position, safe. Is there anything I can get? I can't remember if I did that. Is there anything I can get for you? Here's your call light, open the curtain, go wash my hands. Okay. Now I'm getting ready to say my skill is done. And I just look over to her because Miss Patty said, look at your patient. So I do. And I realize she's a little too close to the edge of the bed. I've already washed my hands. So if I touch her, what do I need to do? Wash them again. Absolutely. Make sense? So what I've taught you applies no matter where you are in the skill. I mean, those rules are the rules. Okay. So foot care is all about inspecting the foot. Now we're using cleaning the foot as our reason to be there. I'll tell you a secret. This is a relatively new skill. It's only been around for about 10 or 12 years now. In the history of healthcare, this is somewhat new. Now, the reason that you're doing foot care is not to clean the foot. These people get showers twice a week in most cases. That's not why you're there. We used to tell CNAs, I want you to make sure that you're looking at the skin on your patient's feet every shift. Just look at it. Now, you're the ones that are putting socks and shoes on the patient. It makes sense for you to look at the feet, right? For me, as a nurse, to come in and look at their feet, I've got to take their shoes off, take their socks off, probably lay them down in bed so I can look at the bottom of their feet, right? It's a lot of work for them, a lot of work for me. If I just ask you, hey, can you just let me know if there's any problems with the skin as you're, doing your skills? That's easier for everybody, isn't it? But the problem is that CNAs didn't understand the why. They didn't understand that as a nurse, I'm responsible for this patient. And if she's got a wound on her foot and nobody's doing anything about it, that's on me. So I would tell CNAs, make sure you're looking at the patient's feet. If there's any problems, let me know. Feet are covered 99% of the time. So if there's an injury, it's not likely to be seen, right? So we would tell CNAs, look at the feet. Well, CNAs wouldn't look at the feet. They would do something like this. That nurse tells me I got to look at your feet. I don't know why I got to look at your feet. Yeah, you got feet. So what? But they didn't understand the why. So because of that, nurses created a skill. We called it foot care. We figured if you're there Soaking the foot, washing the foot, rinsing the foot, drying the foot, and lotioning the foot. At some point, you're actually going to look at the foot. That's why you're there. This is not about cleaning. Make sense? But we're going to clean it like we did hand and nail care. We're going to put the foot in the basin to soak, take it out and put it on a towel to wash, put it back in the basin to rinse, take it out and put it on the towel to dry. Make sure that, you're looking at the foot during that process. Warm up your lotion, put it on, no lotion between the toes, fungal infections, and wipe off the excess lotion. Put their sock and their shoe back on and clean up. That's the whole skill. But understand that when nurses ask you to do something, if you aren't doing it, we're going to create a skill for you. We are going to go out of our way to create more work for you to get the information that we need. Does that make sense? Yeah, it's kind of a crappy deal for you, isn't it? So, yeah, so if the nurse asks you to do something, do it so they don't have to create more work for you. Good? Make sense? All right, mouth care. This is just brushing teeth. Make sure your patient is sitting upright. That's really what this skill is all about, is safety. So get them sitting up. Pillow behind the upper back is better than pillow behind the head. They don't care when you put the head of the bed up. Not graded on the state exam. So infection control does not count on this skill as far as when you put the head of the bed up. You want to do it during your opening, go for it. But you can't touch that patient until your hands are clean. That rule doesn't go anywhere. Remember that. If you want to do it after you've washed your hands, that's fine too. Me personally, I want clean hands in my mouth. So please use a paper towel if you're going to touch the bed controller. It's not clean. Good? Once you get them sitting up, let's put the towel over their chest. Prep your toothbrush by getting it wet, putting your toothpaste on it, and then put your gloves on. Remember, your first thing a glove should touch is the patient. And then you're going to brush. Brushing is one line. One line on that whole checklist. One line. Brush your teeth. After you've brushed their teeth, let them rinse and spit as often as they need to rinse all that stuff out. Here's a tip for the test. Use a very little bit of toothpaste. If you use a lot of toothpaste, you're going to be standing there rinsing for 5 minutes because that toothpaste isn't going anywhere. So it kind of gets all gummed up and it takes a long time to rinse. So a little bit of toothpaste. If you look at a toothpaste tube, it'll tell you to use a pea-sized amount. That is not what they show on the commercials, though, is it? Yeah, they do this whole swoopy thing.
Use it for like 2 weeks.
Yeah, do you know why they do that on the commercials? That's right. That is exactly right, because they are visually influencing you to use more. If you use more, you have to buy more, right? But if you read the actual instructions, this is why marketing and this is why I'll never get big, because I believe in truth, right? That's what I am. Everything I do is based on truth, right? I'm not good at marketing because marketing, you have to have a very loose association with the truth. I'm not good at that. So they're counting on you not reading that package, but because the package says pea-size amount, they're covered. Doesn't matter what they show you in the commercials. The package says pea-size amount. So we tend to get those two things kind of confused, and you've probably never read a toothpaste package in your life. I know. But that kind of applies to this. Pea-size amount is all you need. All right. Once you've let them rinse and spit, dry their mouth. Remember, that's the step that's missed a lot on this skill. And then go clean your basin like we clean all other basins. Put it away using a paper towel, please, because you still have gloves on. Once you get your environment cleaned up, then you can remove your gloves, do your closing, wash your hands. We learned how to count respirations. This is how many times the patient breathes over 1 full minute. Doesn't mean you have to count for a minute. We're going to count for as long as care plan tells us to. This care plan will say 1 minute. Normal is between 12 and 20. If you get less than 12, more than 20, tell the nurse. For the test, you can be off by 2 breaths in either direction. Don't tell the patient that you're counting their respirations because that alters their breathing, but you do want to say start and stop when you start and stop so they can make sure you're measuring for a full minute. Any questions on that?
And you said we could get like an alcohol
Yes,
So
yes.
we can have a visual. Is there going to be, okay,
Top drawer, or they could even be sitting on top of your bedside cabinet. So they'll either be on top or in the top drawer in your testing center. All testing centers, the clinical environment is arranged in a very specific way. Top drawer is grooming supplies, always. Middle drawer, bathing supplies, always. Bottom drawer, toileting supplies, always. You never want your toileting supplies above your mouth care,
Yeah.
right? So think of a human body: grooming, bathing, toileting. That's how our drawers are set up. So your alcohol pads will either be with your grooming or on top, but they can't ever be anywhere below. Okay. I know there are things that we probably wouldn't even really think about, right? But this, yeah, somebody thought about it. So this test is way more scientific than we think it is.
yeah, 'cause I know we practiced respiration in the previous class that I was in, not here. And it was hard because even though we were like not trying to tell them that we were counting the respiration,
Yep.
they were just sitting there and you're like trying to look at them, but not look at them.
Right, right.
Obviously something to,
Focus on.
would have been helpful.
Yeah, that alcohol pad, especially during the test, is super important because if you don't use the alcohol pad, and remember for the test, your patient's going to be lying down, which does make it easier. Trying to see somebody's respirations from a sitting position, much harder.
Yes, it is.
So your patient's lying down. If you use an alcohol pad, that evaluator can stay on the other side of the room. They don't need to be close to you. They're able to see it. If you don't use the alcohol pad, that evaluator may have to get a little bit closer. And now you feel like they're breathing down your neck. You really want them like in the next county would be nice, far away. It just helps you.
You
Okay.
said it's okay to say, I'm gonna take your vitals.
That's what we
Just
want to
like-
say.
that's
Yeah.
Like you're doing pulse.
Right.
Okay, so that's allowed.
That's what we want to say ideally. Now, I'm going to tell you, they're not going to fail you if you say, I'm counting your respirations, because the checklist, the checkpoint is actually very specific on this on purpose. You're allowed to say, I'm taking your respirations. What you aren't allowed to say is giving them instructions on how to breathe.
Yeah, I'm gonna count you now. That's 3, 2, 1.
Yeah. Well, you don't want to say, I want you to breathe slow and deep. Yeah. So but it is better because if you tell the patient I'm counting your respirations, they're going to focus on it and they will change their breathing pattern. It's going to be harder for you to count. So it is better to say vital signs. But if you accidentally say, if you read it off the care plan, I'm going to measure and record your respirations, is that okay? That's not going to fail you. That's okay to do. I prefer you don't, but it's okay for you to do for the test. You can't say, I need you to breathe deep or slow, or don't do that. Don't give them instructions on how to breathe. But you're better off just saying vital signs. And if you get into the habit of that, even with pulse. So all vital signs are vital signs. Yeah, I'm here to take your vital signs. Is that okay? You can do that with pulse. You can do that with respirations. You can do that with blood pressure. It all falls under that umbrella vital signs. And it's perfectly okay to do for the test. Perfectly okay to do out there too. Because your patient doesn't necessarily know the difference between pulse and respiration and blood pressure. It's all vital signs. Okay. This is a documentation skill. Don't forget to document. Anything you count needs to be documented. Range of motion, we've learned 2 so far. We're going to learn another one. CNAs do exercises to retain function. Keep what they've already got. We're not trying to make anything better. We're not trying to improve. We don't go past pain. We don't like pain. Pain is not our gain. So when we're doing range of motion, we're going to follow that care plan. It's going to tell us what body parts, what exercises, and how many repetitions. Follow that. Don't go off-road. Follow that. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around and not on the test. Okay. Lift from below with a flat palm. Move slowly and smoothly and all the way to start. Questions? Denture care, just like mouth care with an extra step. We're going to clean the dentures. We're going to use cold water to clean dentures. We want to put a washcloth in the bottom of the sink in case they fall. Dentures have to be in your hand, in the cup, or in the basin. They cannot be anywhere else. Don't set them down in the sink. Don't put them on the side of the sink. Those are the only 3 places a denture can live. When you're holding that denture, it's going to get slippery. So please be careful. You have to have gloves on to handle dentures. And you're going to brush what you see. So brush the top, brush the bottom, brush the groove, rinse your cup out, put your clean denture and your cup of clean water, put the lid on, put a coaster underneath, and put it on the table. Get rid of that washcloth. We're done with it. We used a washcloth in the bottom of the sink. We're done with that. Get rid of it. Put it in dirty linen. Bring your basin back over to the table. Get your basin ready to use for mouth care because I got to spit in it in just a minute. And then you can take your denture gloves off because you're done with dentures. Now we're going to do mouth care. So put the towel on the patient, get your toothbrush ready by getting it wet, putting your toothpaste on. It can just kind of lay in that basin for a minute and get your gloves on. Brush their teeth. This time we're going to use a toothette, which is a soft, spongy type of oral swab, and just brush what they've got. Let them rinse and spit, dry their mouth, just like we did with mouth care. Remember, that's often missed. And we get to throw that toothette away. Okay?
Not the denture brush.
Not the denture brush. No, but the toothette we will throw away. So the denture brush we'll put back in the basin after we clean it. Right now, the basin's got spit in it. Don't put the denture brush in now. Take it to the sink, clean it out like we clean everything else out. And then on your way to the drawer, I can't say that today. That's a weird word. On your way, use a paper towel to pick up the denture brush and the toothpaste. Use a paper towel to open the drawer and put everything away.
Now, while we are brushing their teeth with the toothette, the denture brush is sitting over on the sink. Should we put a paper towel underneath it?
The denture brush is actually on the barrier on your table.
Okay.
Yep. And it can stay there with the toothpaste.
But we're going to clean the dentures over at the sink.
Right. So let me kind of walk you through that really quickly. So we have our denture cup in front of our patient. Okay. So during our opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to help you clean your dentures. Is that okay? Close curtain. I'm going to take this to the sink before I wash my hands. Just take it over there, take the lid off of it, set it on the side of the sink and leave it. I'm not touching it yet. I'm washing my hands. I'm going to go get my supplies. Get set up. I got my barrier on the table. I've got my toothette. I've got my toothpaste. I've got my oral swab. I've got my emesis basin, 2 sets of gloves, a towel, and a washcloth, all on my table. Did you guys see how you should be able to rattle those supplies off. Okay. So I get my my denture brush ready, dump it in the water, toothpaste on both sides, set it in the basin. It's just basin's holding it. Get my washcloth and my gloves, and we're going to go to the sink. Remember, this is already at the sink, already there. So I've got my washcloth, my gloves, and the basin holding the denture brush. We're walking to the sink. I set the basin down on the side of the sink. I put the washcloth in the bottom, and I put my gloves on. Now I'm going to brush. I brush, 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 brush. When I'm done, I rinse the cup, put some clean water in the cup, put my dentures in the cup, put this here. But while I'm doing that, that denture brush is back in the basin. It's just, that basin's just a holding place. So this goes onto the patient's bedside cabinet with a coaster underneath. Turn the water off, wring out my washcloth, get rid of that. Now I'm going to take that basin holding the denture brush back to the table. Take the denture brush out, set it on the barrier. Now my basin is ready for mouth care. Then I can take my denture gloves off. Okay, good.
So we're going to take the denture gloves off, put the fresh gloves on.
Not yet.
No, we're going to get the toothbrush ready first.
Get the towel on your patient.
Okay.
And toothbrush ready first. Now, because what's first thing our gloves should touch? The patient. Yep.
Okay, so do get the preparation ready, then flip them.
If you guys really, really want to ace the test, I mean, really want to ace the test. I remember those sequencing things that we did on the very first day, right? With hand washing. I've got those for every single skill. You can put these steps in sequence. But if you really want to ace the test, make flashcards of all of those steps. Shuffle them, lay them out, and put them in the right order. Physical, tactile flashcards, putting them in the right order will help you. That's the next resource that I'm going to be creating. Are physical, tactile skill cards, skill order cards. Okay. The electronic ones will help. They help you sequence, but you can make your own at home. Okay, good. Good.
Is electronic ones free?
The
Hmm?
electronic ones are free.
Yeah, electronic ones are free for you. For my students, all of those people, they have to pay $149 for that. Yeah. So by the time you start to add up the books, right, that you guys have, the online course that you have access to, the live streams, the worksheets, and the practice time, all of these supplies that you get to use and practice, you're only paying like $50 to sit in this classroom. Okay, because if you add up the cost of everything that's included. Okay, good, makes sense? All right. Ambulate with a gait belt. Follow the care plan. Your patient needs assistance to stand, but can walk. If you're the patient for this, walk like you walk. Don't overact this. When we're going to ambulate a patient, it's important that we only ambulate them as far as the care plan tells us to. I'll tell you a funny story about this. So my husband had a heart cath done when he was in his 30s. And it's very unusual. It turns out that one of our local hospitals actually got caught recommending heart caths for patients that didn't need them as part of a insurance scam. Yeah, and my husband was caught up in that. So yeah, there were like 200 people that got heart caths that didn't. We're going into your heart.
Yeah, it's
This is extremely dangerous, right? Anyway, for-profit healthcare. So he has the heart cath, and we're supposed to go home. They kept him overnight, and we're supposed to go home the next morning. So I go in, and of course, I'm just the wife, right? And at the time, I was just the girlfriend. I wasn't even the wife. I'm not, I'm not there in a nurse capacity, right? So they said, well, you need to walk around the nurse's station before you go, before we can release you. Well, he wanted to go home. I mean, he wanted to go home the previous night. He was ready to go. So I get him up out of the bed and we start walking. And I'm expecting somebody somewhere along the line to say, okay, you're good. That's enough. And we're going to walk until somebody because I don't have a care plan, until somebody tells us we don't have to walk. We did, and I am not exaggerating, 35 laps around the unit. I counted 35 laps. And I finally said, when can we stop walking? And the nurse looked at me and she says, oh, well, you only had to do one lap. Okay, that would have been helpful information, right? Helpful. So if your care plan does not tell you how many laps you need to do, clarify, right? Ask. Yeah, 35 laps. And my husband's like, this is ridiculous. How much do we have to walk? And I'm expecting it because the nurses are watching us go by and by and by. And what are you doing? Yeah, exactly. But nobody did. Nobody intervened. And communication is so important in healthcare because your patients don't know what's on the care plan. Right? You are the intermediary. The nurse is the intermediary. So, that's still.
Now, I mean, they obviously need help getting up. Is there, I mean, granted, on the test, I know it's not gonna be like this, but in a healthcare setting, could they need help getting up and then you would give them their walker to help them walk?
Absolutely. And that would be on the care plan, right? Patient walks with a walker.
Okay.
Yeah. Have you ever seen an old person try to get up? Okay. It's the rock and roll method. Yeah. Rock and roll method, right? So they start to rock,
Oh, yeah.
right? And then they try to get up and gravity pulls them back down. And then they try again. How much energy does that take? Now, if you remember our energy conversation, they've only got this much energy. And if they're using that much every time they get up, and think about how many times they go to the bathroom, how many times they get up for activities, how many times they get up for meals, it's a whole lot of energy. By the time we get to 4 o'clock, they're not eating dinner. They are out of energy. They're done. That shower you want to give them tonight, yeah, hang that up. That's not going to happen. Okay. So if they're that tired and they're not eating tonight, what's going to happen to tomorrow's energy? Less. And this causes a downward spiral. So energy conservation becomes a very important topic when we're dealing with the elderly. And that's why helping them to stand, there's an inverse relationship between strength and effort. Okay. The more strength you have, the less effort it takes. All of you can stand up out of your chair like this, no problem. But what if your legs lack strength? You're not going to be able to just stand up because you don't have the strength, which means it's going to take more effort, energy. Does that make sense? So when we have a patient that has limited strength, either due to age or due to illness or due to an effect of a condition like a stroke, prolonged illness can cause weakness. Here's a good statistic for you. If you are 50 and below, that's our cutoff, 50 and below, every day that you are inactive, it takes 3 days of recovery. So you get the flu, okay, and you're down for 2 days. That means your strength is not going to return for 6. You'll slowly build, but your strength won't return for 6 days. This is why you're like 3 or 4 days later, you're like, why am I still so tired? I'm over the flu. Well, you're not over the recovery period. For every decade after 50, we add on another 2 days. So 50 and below, 3 days recovery. 50 to 60, 5 days recovery for every day you're down. 60 to 70, 7 days recovery for every day you're down. 70 to 80, 9 days of recovery for every day that you're down. Does that make sense?
If they're on a walker and you've got the gait belt to get them up, are you still going to hold the gait belt as they're on their walker?
Yeah, because if they start to get wobbly, I don't want to grab their arms to pull them to me. I need something at their center of gravity. So that's one of the reasons that they are here, okay? And I'm slightly behind and to the side. My hand is here. My attention is on them. So as we're walking, okay, we're walking, they get a little swirly on me. This leg, and I always have the patient on my stronger side, right? This leg, my stronger leg, gets planted between theirs. And I do this, you don't even think about it. As you're walking, they get squirrely, you plant your leg, you stop. You okay? You all right? Let's go ahead and sit on the ground. Let me get somebody to check you out before we fall.
I do the same thing with my mother-in-law. Like, I take her for a walk or whatever. When she gets tired, we stop and she doesn't have a gait belt yet. But we just turn her walker around and she sits on the walker and rests.
Yep. And that's good. That's good. You've got an exit strategy there. The big thing is don't try to rush her anywhere. She's not going to make it. No. The walker with a chair on it, with a seat on it, that's an awesome idea because the problem is that turning around process can take some time. So you might lose her in that time, right? She might just crumple. So that's where that gait belt is going to be so important because if she starts to crumple, you can pull her against you and essentially you're kind of breaking the fall. Okay. Does that make sense? Okay. And yes, I would absolutely recommend a gait belt. Yes. You can order them off of Amazon.
Oh, yeah.
They're in the practice kits too. All right. When we lift a patient, you want to use proper body mechanics. Standing at an oblique angle is better than straight on, better for your body mechanics. Their hands on your shoulders, your hands around the side or the back of the gait belt. And on the count of 3, you're going to lift 1, 2, 3. Once we get them standing, we're going to ask, are they okay? And then we're going to walk. The walking is just 5 steps in one direction. The walking is not really what they're grading you on, other than they're watching to see where you are. Okay. When you get them back to the chair, turn them around so the back of their knees hit that chair. They know it's there, and we're going to help them sit using the same body mechanics. Patients must be wearing shoes to walk. All right. Partial bed bath. Don't cross-contaminate. We're going to use that leaves method. And the care plan is going to tell us to wash face to waist, front and back, one arm and hand. So whatever we wash, we rinse. Whatever we rinse, we dry. I mean, the same washing rules apply. You know, check the water, they check the water. All of those same washing rules apply. Face first, no soap. We don't want to put soap on the face because it stings the eyes, it dries the skin. We're going to, where am I here? Use the leaves method. Oh, control the washcloth. No floppy corners, right? You don't want to be whipping them as we're washing them. Support all extremities while lifting. We're going to turn on their side to wash, rinse, and dry their back. Give them a brief back rub with long circles, just, you know, long strokes and circles. And we'll apply lotion last, tie the gown. Clean up. Long skill. This is a long skill. This is a super long skill. But if you get this one, if you look back on page 25 in your book at all of those care plan sets, it's only on 1. So you have a 1 in 11 chance of getting this skill. And if you get it, you get 2 super short skills to go with it. You get a range of motion and you get respirations. So even though this is a super long skill, you get 2 easy ones to pair with it. So it kind of evens out. Okay. And it's only on 1 care plan set. Only on 1. Yeah, the evaluators don't like this one just because it takes forever. And you guys are so micro-focused. And yeah, exactly. And they're like, oh my gosh, just wash the patient. Just wash them. How would you wash a baby?
I know, but
Wash
we-
them.
We practiced. We realized after we were totally done that we rinsed the front, but we never dried the
So, yeah. And what did I tell you when we were going over washing rules? You will forget a step, and we won't forget it on ourselves. But when you're doing this on somebody else, you will forget a step, which is why in your head,
especially because it's a mannequin and they can't. You're not like they're not communicating with you. They're not like, I'm cold or
right? But your patients may not either.
Yeah.
So when you're going through these steps, I want you to, in your head, you can say them out loud too. It's perfectly okay. But in your head, I want you to say, whatever I wash, and stop, wash, I rinse, rinse. Whatever I rinse, I dry. And if you do that, if you can get your brain to, and I do this, I mean, unconsciously, if I'm going through the skills, I actually, in my head, I keep track of my steps just like that. Whatever I wash, I rinse. I got to rinse.
It's funny because we were having the same conversation at home with washing dishes because my brother-in-law was getting on to me about something, and I'm like, I know, whatever we wash, we rinse. Whatever we rinse, we dry. He just looked at me like I was crazy.
It's perfectly okay. Perfectly okay. Did I tell you guys about my hand washing story when I went to, I was in a big box store, and there's several women in the restroom, and I use the restroom, and I go to the sink and I'm washing my hands, and most people are going in just doing a quick rinse and they're out, right? And I'm washing my hands, and there's somebody standing behind me, and I really didn't pay attention. I remember I've got like 5,000 graduates now. I'm not going to remember all of you. I'm just not. So somebody's standing behind me, and I hear somebody laughing, and I don't pay attention. Everybody's got their phones, right? You're probably watching a puppy video or something. So I'm not paying any attention. And then I hear the voice, you really do that all the time, don't you? And I turn around, and she says, you really wash your hands like that? I said, well, yes. And she said, I just thought that was for the test. And I'm like, do you know how many germs are in here? Yeah, no, if I'm going to wash my hands, I'm going to make it worth it. Otherwise, what's the point? You know, you're not getting all the pathogens off. What's the point? So, yeah, I really do wash my hands like I show you. Yeah, and I do the same thing. Whatever I wash, I rinse. Whatever I rinse, I dry. All these things that I tell you are still in my head, too. If I'm going to touch something ooey gooey, I'm going to wear some gloves. I don't care who it is. I did that with my son, my oldest son. He got injured. I go to do a dressing change on him. I put on a pair of gloves. He's like 17. He's like, Mom, I'm your kid. Yes, but you've been out of my sight for 15 minutes and more. Don't know what you've been into. So, yes, it's ooey gooey. I'm going to wear gloves. Absolutely. Absolutely. And I don't want to contaminate the wound as well. So, we have to be, this stuff is going to apply to real life as well as. So one of the things that I'm really into cooking, I do a lot of cooking, and almost my entire Facebook feed is nothing but cooking, you know, recipes and stuff. And it's become very, very big right now. I mean, Instagram, TikTok, there's tons of cooking stuff. And one of the big trends right now is to wear gloves when you're handling raw meat, right? And I find this, and I get it. Nobody wants to touch meat with their hands, right? It's ooey gooey, it's icky, and I understand that. However, the problem is that when they put those gloves on and they're touching that meat, they no longer think about what else they're touching. And the whole point of the gloves is to prevent contamination, right? And yet they'll touch the spatula and they'll touch the pan handle and they'll,
Like kind of like when they were making the sandwich in public.
yep, absolutely. Because you stop paying attention to what you're touching. And I'll kick my feet and like, you just touched the refrigerator with those chicken covered gloves. Wash your hands.
Well, and there's this one lady that I watch. She's got a kind of vulgar mouth, but she's like, if you've touched raw meat, wash your.
Oh, yes. Of course I made it. Of course it's good. I made it. Yeah. Yeah. I love her. She is hilarious.
Right, but like that saying is in my head, but and I'm not going to use that word.
Yes.
So I'm like, it goes through my head, but I don't know.
Yes, yes. And I absolutely agree with that.
Yeah.
Wash your expletive hands. Yes.
It's actually crazy because I used to be in the food industry, and a lot of the cross-contamination things are the same as in nursing or, you know.
Absolutely.
CNA, you know, you don't touch food with the salt or, you know.
Right.
Yeah, so that's made it a little bit easier.
Oh, good. Very good. Very good.
And I don't know. I've been fortunate. Both my kids don't have any allergies, but I always worry about the kids because as a teacher, I taught for 32 years. So as a teacher, you know, my kids with allergies and everything, I always worried about, you know,
What's coming in?
If I was their parent, I was like, if I would have been their parent, I would have been like a nervous wreck knowing, like taking them to a restaurant or something, because, you know, even though you're like, my son has a nut allergy, you know, you don't know what's going on in the kitchen.
Right. And you have no control over what's going on in the kitchen. Yeah. Yeah. I know it's challenging. Challenging for sure. All right. So any questions on the skills that we've gone over so far? Are you good on the principles that we've learned? All right. So today we're going to we're going through, I think it's 3 skills. Sorry. We're going through 3 skills. And we're going to utilize a lot of the principles that we've learned so far, but we're also going to learn a few new things as well. Some modifications that we're going to be taking. But one of the big ones that I really want to stress, and this is what we've already stressed earlier in this class, is that we need to be making that transition now from step focused to patient focused. And the skills that we're going to be doing today are going to require us to do that. Okay? So everybody good with that? All right. And remember, we have flashcards. Okay, so here's our first skill that we're going to learn. Page 72. We're going to transfer from bed to wheelchair. So if you remember everything that we learned in Ambulate with a Gait Belt, we're going to use that same all of those same principles that we learned in this skill. So instead of getting our patient up and walking them, we're going to pick them up or help them stand, not pick them up, help them stand, pivot them, and sit them down in the wheelchair. We're going to look at this care plan very closely, though, because there's a part of this care plan that everybody just kind of overlooks, and it's the key to passing this skill. There's nothing new to learn here. We know all of these principles. We've learned all of the principles now for all skills. So now it's just rinse and repeat, rinse and repeat, rinse and repeat. And that's why we should be at this point starting to transfer our focus from that back wall to the patient.
Are these the skills that you want us to do flashcards about in the ground?
Yes, yes, absolutely. All right. So if you look at the bottom of the page, you'll see that somebody with your level of experience should be able to do this skill in 11 minutes or less. That's a long time. All you're doing is getting the patient out of bed and into the wheelchair. And you're getting 11 minutes to do that. This skill is one that I think that they give you way more time than you actually need. They should take a couple of these minutes and tack them onto denture care, I think. This is going to be a live patient skill, so one of you may be the patient for this. If you are the patient, you are going to get some very specific instructions. This skill and the next one that we're going to learn require patients to act a certain way or do certain things, I should say. This person is going to start out in bed, and this is not a documentation skill. If you go to page 73, you can see the care plan at the top of the page, followed by step-by-step instructions. I'm going to bring your attention to this graphic at the very bottom here, the bed and the wheelchair. That graphic is not correct. That'll be changed on the next revision. That wheelchair is not close enough. Looks pretty close, doesn't it? That wheelchair is not close enough. Keep that in mind. The bottom of the page, you see your supplies. So you're going to need shoes. You're going to need a gait belt and a wheelchair. So here's our care plan. And this is, I'm going to go over the very specific part of this that everybody overlooks. Transfer the resident from bed to a wheelchair. The resident is unable to walk or take steps. You might want to highlight that or underline it or mark it in some way. But can stand with support. So we're just, remember, this is an energy deficit. They just can't quite, strength deficit, right? We're going to help them stand, but they cannot take steps. So if we go back to the other page and we look at that graphic, that wheelchair is too far away. This patient, when we turn them around, they're going to have to take a step back to sit in that wheelchair. So when we position this wheelchair, it should be close, like super close. Like I should only be able to fit a piece of paper between the wheelchair and the patient, super close. Otherwise, your patient's going to have to take a step. If you are the patient for this skill, you are going to be told, do not step back. Okay. Right. And you're going to want to, because it's normal. But what if the patient can't? Our care plan says they can't. But here's the problem. Remember I said that before we sit a patient down anywhere, they've got to be able to feel the chair behind them before we sit them down. Well, that's what's going to happen here. You're going to lift the patient and turn them. They're not going to feel that chair behind them. So they're going to resist. And that's how falls happen, by the way.
It also doesn't say anything about shoes, and if they're going to step out of bed, we have to make sure their shoes are
Right, we're going to talk about shoes in just 1 second. Yep, we're going to talk about that. Says a gait belt or transfer belt is required to transfer the patient, and the resident will stay in their room. So this care plan doesn't tell us about shoes. How many people do you think are wearing shoes in bed? 0. So, but we know, even though our care plan doesn't tell us we need shoes, it's a principle. Do you guys remember me saying that nothing on the back wall will be on the care plan? These are things that we have to know. So that's why we start learning those, because they're not going to be up here. Does that make sense? So even though our care plan doesn't tell us to put shoes on, we know that if the patients hit the floor, feet hit the floor, we got to talk about their shoes. So that's a principle at work. All right, we know all of this. There's nothing new to learn here except for our skills specific steps. So let's go over those. Let's talk about wheelchairs. So wheelchairs, there's a couple of different parts to the wheelchair. There's the seat part, there's the back part, there's the handles where we use to push, and then we have the working parts. We have brakes on both sides, we have foot pedals, and we have leg rests. Now, all of these move. Okay, the rest of it is stationary. This is the part we know about. These are the parts that move, the brakes, the foot pedals, and the leg rests. Now, these brakes have to be engaged if the wheelchair is not moving. So if we're going to put a patient into the wheelchair, we need brakes. If we're going to take a patient out of a wheelchair, we need brakes. If we're going to leave a patient sitting in a wheelchair, we need brakes. If we're going to move a patient down a hall, no brakes. Good? Got it? All right. So foot pedals and leg rests move. So the foot pedals fold up and down. Leg rests move out. There's a little catch, and you can't see it in this picture very well, but right here is a little catch that controls that leg rest. So you open the catch and the leg rest swings out, and I'll show you that on our wheelchair. We actually have this wheelchair, it's just in the back. So when we're talking about foot pedals and leg rests, there's three very specific configurations that we have to know. This could be a written test question. This could be a written test question. It may ask you, what configuration does a wheelchair need to be in when it's when your patient is being transferred into it? And that would be this one. We want everything clear, nothing to trip over. What configuration should the wheelchair be in for storage? We want the foot pedals up and the leg rests out, just like you see here. What configuration should the wheelchair be in when your patient is in it? No, it's good. When your patient is in it, well, those foot pedals have to be supporting the legs. We're going to talk about why in just a minute. So there's three different configurations based on what we're doing with that patient at that moment. This was a lawsuit in Georgia, and this one I felt really bad about. I really felt bad about this. So what happened, because this was just a worker trying to be a good person, right? A good person. So this older lady had gone to the hospital or the healthcare setting. I don't know if it was outpatient or a hospital, I'm not sure. And she was getting an x-ray. Okay. She was getting an x-ray. So she got her x-ray. She's sitting in a wheelchair. The daughter goes to get the car, pull it up around front so the patient doesn't have to walk very far. And the patient is sitting and sitting and sitting and sitting and waiting. And the daughter's in the car. And the receptionist is watching this whole thing. She called a transport person, but the transport person didn't come, was busy, something, I don't know. So the receptionist, being a good person, says, well, I'll just take the patient out to the car and help her load. And the receptionist was not trained on how to properly use a wheelchair. So she figured it's a wheelchair. It can't be that hard, right? So she pushes the patient outside in the wheelchair, but she did not flip up the foot pedals or move the leg rests out of the way. So we've got a wheelchair that is in the use position. Patient tries to get up out of the wheelchair to get into the car. Her legs get caught in the foot pedals. She trips, falls, breaks her leg. Now she's going to be admitted. She's not going home. And there was a lawsuit over this. Now, the lawsuit was because an untrained individual performed a medical procedure. This receptionist got fired.
She just wanted to be a good person.
She wanted to be a good person and help. She got fired. The facility was sued for millions of dollars, and the patient won.
broke her leg at
She broke her leg at a medical place.
Yeah.
I mean, yeah, that's a lawsuit. If I was at a medical place, I would assume that anybody that's there to help me is trained to help me with what they're helping me with, right? So even though our brains might say, oh, this is easy, we can do, you don't, what do you need training? It's a wheelchair. Yeah, right? So we have to be super careful with, have you been trained to do this task? If you remember all the way back to class 1, we talked about this, right? CNAs do normal routine tasks on stable patients that we have been trained to do. The receptionist had not been trained. Because of her ignorance, a patient was injured pretty severely.
But if the daughter had gotten out of the car and gotten the mother out of the wheelchair, would it then have been the daughter's fault?
Yeah, it would have.
Because if, let's say the receptionist just wheeled her out and was like, okay, she's your mom.
Well, the receptionist should never have wheeled her out. If the daughter came in and got her, that's different.
Yeah.
But the receptionist called transport. They were waiting on transport who had been trained. If the receptionist took her out, a case could have been made that she shouldn't have wheeled her out, that the patient, it was forcing the situation. The patient should have waited for the right help. So I would advise you to not do anything, no matter how simple it looks, to not do anything that you have not been trained to do or specifically authorized. And I feel super bad for this receptionist because all she wanted to do was help. Her heart was in the right place. Unfortunately, the patient's leg wasn't. Okay, good. All right. So I want to talk to you about foot pedals now and why they're so important. Now, unfortunately, hey, Jake, can you follow me? No, I probably should stay over here to follow. You going to manual or?
Yeah, I'll manual.
Okay, manual. All right. So here's the wheelchair. Okay. Good. So here's the wheelchair. These leg rests have a little catch that just release them. And then they go to the sides. This little catch releases them. So this little catch is right here. You just pull it and it opens up. When you close it, they snap in. Okay, that's how you do leg rest. Now, the problem is the whole thing comes off. That easy. It really is that easy. So these get lost all the time. All the time. People take these off, they throw them in the dirty utility room for somebody to clean, and now you got a wheelchair without leg rests. So why is that a problem? They literally just set on these 2 pins. They just set in place on those 2 pins. Okay. So why is that a problem? Well, it's a problem because of that. Oh, yeah. Go ahead, Jake. Yeah.
Oh, perfect.
Got it? So they just set on those. Most, yeah.
Yeah, they are.
Yeah.
I mean, my mother-in-law has one when she needs it, and it's a different color, but it works the same way.
Yeah, most do.
Because I remember trying to put it in the car, and I'm like, oh,
Yeah, they fell off. Yeah, that's normal. Okay, so why is this a problem? Let's go back over here and let's talk about this graphic. So you have veins and arteries running down the back of your leg. Now, arteries take blood away from the heart, veins bring blood back to the heart. So we have arteries going down, we have veins coming back up, and they kind of congregate at the back of your knees. So that's where the skin and the muscle is the thinnest. When we sit, that's the part that bends, right? Well, we have gravity on planet Earth. So when you're sitting in a wheelchair, that seat is going to press into that area and it compresses it because of gravity, compresses. Now, if you remember, we talked about what happens when tissue gets compressed, right? We don't get good blood flow. It leaves us open to things like pressure areas. But there's another danger here that's actually way worse than pressure areas, and it's specific to this. So when we have compression of those vessels, that traps blood from being able to get back to the heart. So we have blood going to the legs, but that blood can't get back from the legs to the heart. So that causes swelling. It also causes a risk of blood clots. Because when blood slows down or stops, it clots. We talked about that last class, right? So if I have compressed this vein, inside the vein are these little valves. And this kind of creates like a ladder system. So when the heart beats, the blood from this section gets pushed up through the valve into this section, the valve closes, and it keeps the blood there, because otherwise gravity would just pull that blood back to the feet. So this allows the blood to climb this ladder type system back up to the heart. So when we compress these veins, it compresses these valves as well. So now the blood just kind of sits there. It doesn't go where it's supposed to go. And blood that slows down or stops clots. So when we have a patient in a wheelchair and their legs are just dangling down, they are at risk for swelling, but also blood clots. So in order to prevent that from happening, we're going to support those feet on those foot pedals. Jake, take that down for 1 second. Support those feet on foot pedals, and that helps relieve that pressure on the back of the knees. It allows for better blood flow. Do you guys see how important those foot pedals are? They're not just an accessory. And the problem is they come off super easy. So if we put a patient in a wheelchair with no foot pedals on and their legs just dangle, there's a risk there to that patient. And we have to be aware of that risk. Okay, Jake, go ahead. Good morning. At what point do we do transfers? We were told not to when we go for our clinical. We should allow those who work there to do it. You will follow the care plan, right? So you're going to follow the care plan for the patient. But in this case, as a student, you're also going to follow your care plan from your instructor as well. So it's super important that you listen to your instructors. And I can tell you why. This situation that she's talking, Anna, this situation that she's talking about just made national headlines, and it's from Ocala. National headlines. A nursing student, not a CNA student, this is a nursing, but it could have been a CNA student, a nursing student in a hospital in Ocala did not follow the care plan. Patient called on the call light, asked to be gotten up out of bed, and the nursing student never consulted anybody, never consulted the nurse or a care plan or anything. Patient asked to get up. Nurse went to transfer the patient and get them up. Patient fell, cracked their head, died. Now, this person, by the way, is currently a nurse. Completed training, took their state board, and is now a nurse. But the hospital got sued. It's actually a male. Yeah, he. So that hospital then turned around and sued the school. The school. That's right. So why would the school be liable?
Because they trained him.
Okay, so they trained him.
And the school carried insurance on that student.
Okay.
To go into that hospital.
The school had the insurance, but the students are only allowed to do what the instructor allows them to do. The instructor is the one with the liability here. Does that make sense? Just like as CNAs, you don't have liability. Who has the liability? The nurse, right? So same thing with students. The person who has the liability is always the nurse. Well, in this case, the nurse is the instructor. So the instructor should have stressed over and over and over again that we do not make the rules, we follow the care plan. A licensed nurse has made the care plan. They are the ones with the liability. We follow that. If you can't follow that, you go let a nurse know. That, what I taught you in the first 15 minutes of this course and have reiterated every class since, is because of that situation in Ocala that made national news. Now, this is relevant to you, for sure, relevant to you. But to me, I always go back to the patient. How horrible is it that the patient lost their life because somebody didn't follow a care plan? How horrible is it that the family lost their loved one in a clinical setting? Right. From a medical error. How horrible is that? So what we do matters, guys. It matters. And Anna, that's why they're telling you, do not transfer patients. So when you get into a clinical setting and you are now an employee, you will be transferring patients, but always, always, always follow that care plan. So everybody understand why foot pedals are important? Thank you, Jake. All right. So we're going to have to get our patients sitting on the side of the bed to put their shoes on. Don't put shoes on when they're in bed. That's gross. So we're going to get the patient sitting on the side of the bed and put some shoes on. We're also going to put the gait belt on. Now, when we do this, though, we want the wheelchair somewhat close, within reach. Not super close, because we got to swing their legs out. Their legs are going to get tangled up in that wheelchair if it's too close. Within reach. Close, but not too close. We're going to swing them out so their legs are sitting on the side of the bed, put some shoes on, grab that gait belt, put it around their waist, and then we're going to get that wheelchair super close. Okay. Before we do that, we want to make sure our wheelchair is prepared properly. Those foot pedals are up and the leg rests are out. So our wheelchair is wide open where we're going to be transferring the patient into. Super important.
And make sure the brakes are on.
Yes, yes. So in order to get the patient sitting on the side of the bed, we're going to use this technique. This is not as hard as you think it is. You can actually turn somebody as large as you or a little bit larger. The problem is everybody tries to do this wrong. Okay, if I'm going to swing this lady to the side of the bed, so she's sitting on the side of the bed, I'm going to put this arm under her shoulder, and I want to put it as far under the shoulder as I can. Her far shoulder should be in the palm of my hand. I'm not just going to do this. This doesn't help. All the way under, because I'm going to use my whole arm to pull her, not just my hand. This arm, though, is the one everybody gets wrong. Everybody tries to do a honeymoon carry, okay? Put the arm under the legs. Well, now I've got to push and pull, and that torques my back, and I have no leverage. This doesn't work. This does. If you put the arm over the legs, so under the shoulders and over the legs. I always think of that song from a million years ago, over the river and through the woods to grandmother's house we go, right? So I can't sing, by the way. But this is under the shoulders and over the knees to the side of the bed we go, okay? If you put your hand under the shoulders and over the knees, it's just a simple pivot. And it doesn't torque your back. It gets the patient sitting on the side of the bed very easily. It doesn't take a lot of upper body strength for you to do that because you're not pulling. You're turning. Now, if you have very little upper body strength, you can put the head of the bed up to make this a little bit easier because now you're not lifting, you're just literally turning. But you lose momentum. There's always a give and take here. I do this with the patient lying down because I want that momentum to get them sitting. If you put the head of the bed up, you lose your momentum and it actually takes a little more strength to do. Good? When you get them sitting on the side of the bed, you need to let them dangle for a second. This is a turn. This is a sudden turn. So their brains might need a minute to recalibrate. Okay. Get them sitting on the side of the bed. Let them sit and dangle for just a moment so that they can regain their equilibrium. While they're sitting, it's a good time to put the shoes on. Shoes will be right beside the bed.
What if they touch the floor?
So, well, their feet can touch the floor. It's okay. You're not really going to be able to get away from that because we're turning them. Don't put their shoes on in bed. Ideally, the little area that they're touching beside the bed doesn't have a ton of pathogens, right? We're not in a bathroom. We're not walking in the hallway. This area should be pretty clean. If there's a concern before we put the patient back to bed, we can change those socks. So they're getting back into bed with clean socks. Good? Makes sense? Okay. So we're going to get them sitting on the side of the bed, and we're going to get their shoes on while they dangle. Then we're going to put the gait belt on. When we put the gait belt on, we want to check it with 4 fingers to make sure that it's securely fastened around their waist. And that is a graded checkpoint, by the way. And we're going to bring that wheelchair close. And do you see how close this wheelchair is? We want it close. When I pick that patient up and turn them around, the back of their legs should be up against that chair. This is a pivot transfer. Make sure those foot pedals and leg rests are out of the way and the brake is engaged. So brakes, let's talk about brakes. All wheelchairs are a little bit different. There's 2 ways that brakes work. You either push forward to engage the brakes or you pull backwards to engage the brakes. Doesn't really matter. It's just 2 mechanisms. Find out which one your wheelchair is. And the way that you tell is all brakes work the same way on a wheelchair as far as the mechanism of action. There's a metal bar and there's a wheel. If the metal bar is biting into the wheel, it's locked. If the metal bar is away from the wheel rolls, it's unlocked. You may have to push forward for brakes. You may have to pull back for brakes. Doesn't matter. It's just, is the metal bar biting into the wheel? Okay. Feet have to be flat on the floor before we transfer. That makes sense. We've heard that before. And we're going to use that same oblique angle. 1 foot in front of their feet, across in front of their feet to keep those legs from coming out. 1 foot parallel to their body. And then on the count of 3, we're going to lift. 1, 2, 3. And we're going to pivot. When we pivot, we want to ask, can you feel that wheelchair behind you? When they say yes, we can sit. Now, there is an easier way of doing this. Because when I'm standing here and I'm lifting the patient, 1, 2, 3, we lift up, over. If I have to stop and say, can you feel the wheelchair? And I have to wait for them to say yes, that's a lot of time of this. So I don't do that. Let's go back over here. Mr. Jones, when I lift you up and turn you, you're going to feel that wheelchair behind you. When you feel that seat behind you, I want you to say sit, okay? All right, put your hands up here. I'm going to lift you up. When you feel that chair, say sit. Ready? 1, 2, 3, up, over, sit, down. I'm not holding the patient. Prep work makes the job easier. Once you get them in the wheelchair, make sure they're seated properly. Feet on the foot pedals, hips against the back, sitting up. Just look at them. Do they look good? Remember, look at your patient. All right, then we can take that gait belt off. Don't pull the gait belt when you remove it. Make sure your patient looks comfortable. That's really what this is all about. So now we know all of the steps, the principles and the skill specifics. So let's apply those to this checklist. Now, this is a long checklist. There's a lot of steps here, but you know most of them. We're going to consult our care plan to tell us what to do. We're going to do our opening to get those check marks. We're going to evaluate if we need gloves. Now, for the test, your patient is fully clothed and holding on to all of their own body fluids. Yay! But in a clinical setting, that may not be the case. You may need some gloves for this. We are going to, let's see, where am I? We're going to use our shoe rules that we've learned. That tells us that we need shoes on. It tells us to count to 3 before we lift the patient. It tells us how to use the gait belt. Remember all those things that we learned on shoe rules that won't be on our care plan. we're going to use our skill-specific steps, and there really aren't that many for this. And we're going to do our closing. So when you look at this, yeah, we've got a couple of things in black, but most of this skill is going to be on the back wall. Good? All right, please remember that this skill is only for this patient, nobody else. So some patients out there, like Anna was asking, some patients out there, CNAs will not transfer them. Not your job. That's going to be the transport people's job because we hire the big burly guys. Yay. Okay, some patients will need to be transferred. It'll be on the care plan for you to do. In that case, we're going to use these rules to make that happen. Every patient is going to be different. Remember that this care plan is just for this patient. Other patients may have different accommodations. Good? All right, Jake's going to play this video. We're going to watch the video, and then after the video, we're going to take our break. You got it?
Hello.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Would you like to get out of bed and into the wheelchair?
Yes, that'd be great.
Okay, I'll be happy to help you with that. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll grab the gate belt. And I'm going to bring the wheelchair within reach, but not too close to the bed. All right, Mr. Jones, I'm just going to remove your sheet. We'll pull it all the way to the end of the bed. And I'm going to help you sit up on the edge of the bed. So to do that, can you scoot your body toward me? That is locked. You're going to cross your arms over your chest and relax. I'll do all the work. I'm just going to pivot you around so you're sitting on the side of the bed. Please let me know if you get dizzy or unstable at all. So I'm going to wide base of support, leaning against the bed, making sure the wheels are locked. I'm going to place one arm all the way under the shoulders and the other arm over the knees, bending at the knees, not the waist, and we're going to pivot. 1, 2, 3. Good?
Yes.
Okay, you can relax your arms. I'm going to help you put your shoes on now. Okay, first shoe and the second shoe. And are your feet flat on the floor?
Yes.
I'm going to place this gate belt around your waist, making sure that it's not twisted or kinked. And we'll secure it by sliding the gate belt into the first guard, pulling it so that it's snug. We'll check it with 4 fingers, and then slide it through the second guard. I'm going to bring the wheelchair close at a slight angle, almost touching the patient. And we'll lock the wheels. All right, Mr. Jones, can you bring your feet together and back a little? Are your feet flat on the floor?
Yes.
You're going to place your hands on my shoulders. I'm going to lift you to a standing position, pivot you, and when you feel that seat behind your knees, I want you to say sit, and I'll help you sit.
Okay.
Okay, you're going to place your hands up here. And on the count of 3, we're going to lift and pivot. 1, 2, 3.
Sit.
And we'll remove that gate belt. Okay, and I'm just going to bring the gate belt behind you and turn you around to get your feet onto the foot pedals. So we're going to turn around. I'm going to bring the first foot pedal forward. Make sure it locks into place. And then place the foot on the foot pedal. We'll then lock the wheelchair. I'll lock this side, support your leg, bring the leg rest and the foot pedal, and support the foot. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light. Here's your call light. If you
Thank
need
you.
anything at all, just press that red button and somebody will be happy to come help. I'm going to open the curtain and go wash my hands. On the way, I'll return the gate belt to storage. After washing my hands, I'll think about my skill, make any corrections, and tell the evaluator my skill is done. Oops, sorry, I forgot to hit light. Right, so the gate belt is there to lift at the patient's center of gravity without using their pants, which is going to give them a wedgie. Okay. All right. Any other questions on that? Let's go ahead and take your break. Come back in 15 minutes and we're going to get into feeding. Thank
they're,
you.
like, giving you an appointment, and you
Well, let
go,
me
"It's
grab my
like a
drink.
few minutes, you just
Oh,
give
you
your
already
fingerprint."
went?
Yeah, I did. Yeah. It's like you don't have ever have trouble with that little phone down here,
And it's all like, it's electronic, so you don't even have your fingers don't
I've
even
never
get
really.
So you just find it.
No. I read it. I read the book.
I know
never
that. I
read-
read.
Yeah. No. I never read the questions first. Actually said, yeah, I read the book and I answer it. That's why I take time.
Yeah, it shouldn't be hard for you to find the answers. The reading is really very it's written at a 6th grade level. So it should be pretty self-explanatory, pretty easy to find the answers. But here's the problem, okay? And I want to be very clear on this because a lot of people get this confused. The test questions that you are going to get are not in that book. Okay? They're not in the game show, they're not in practice tests. There's something called test integrity, which means that the actual questions cannot be leaked ever. Because if there were pirated copies, the test would be no good because people would just memorize answers.
Yeah.
It doesn't mean that you wouldn't be learning anything. Okay. Does that make sense? So nobody's going to give you the actual test questions. What I'm doing in the book is helping you gain the knowledge that you need to answer any question that they ask you. Okay. So that's why the reading becomes important because there's something in there. Everything that you read, there is something in there that could show up on the test. Okay. Nobody can give you the test questions. And to further complicate it, there's 6 different versions of the test. So every person that's taking the test on test day has a different test questions, different order of answers. So if you look at her, she's sitting next to you and you look at her screen, she's going to have totally different questions than you have. Now, all of the questions have been vetted, which means that this is going way deep in the woods, but you get 60 questions on the state exam, but only 50 of them count. You don't know which 10 don't count. The 10 that don't count for you or against you, those are what we call trial questions. So they're trying out some new questions. As long as over X percentage pass that new question, it's a valid question. It's not misleading. It's not confusing. It's a good question. That will then become a graded question on a future exam. Make sense?
Mhm.
So that means that all of you guys have different questions. So I don't know which questions you're going to get. I don't know which questions you're going to get or which ones you're going to get. That's why the reading becomes important because you may have a question on culture, but you don't have any. Your questions are on prioritization and organization because all the questions are going to be different on the different versions of the test. That's why the reading becomes so important. I'm covering about 80% of what you need to know in the class. About 80%. And if you read, you'll notice that a lot of the stuff you're reading is stuff I've already talked about in class. But there are some things that I'm not covering. And that's why that reading becomes important. So if you're catching yourself reading for a long period of time, but not really paying attention to what you're reading, that's your clue to get up. Go do something. Go wash the dishes. Go walk the dog. Go play with the kids outside. Go take a walk. Activity that is mindless, things that you don't have to really pay attention to, allows that information you just read to be sorted and filed in your brain. That's why I say activity, fold the laundry, walk the dog, do the dishes, and then go back to it and read a little bit more. Now, everybody's attention span is different. Mine, I can sit down and read for 30 or 40 minutes and retain everything. And I have an eidetic memory, which means that what I read, my brain actually takes a picture of that page, and I can tell you exactly on that page where that answer is. It's just the way my brain works. Going through school, I was very fortunate. I never had to study. So everything was right there, right? So I was very fortunate, and that's not me. That's just that's I was very fortunate. Not everybody has that. Other people have to work really, really hard to retain the information, and I understand that. As I get older, it's getting harder, but I understand that. All I can do is give you strategies to help you. Okay, you're welcome. All right. Learning how to take a test too is important. A lot of people don't really know how to take a test, and that's why I do the game show. So if you haven't watched the game show, I would highly recommend that you do, because when you take practice tests online, they can only tell you whether your answer is right or wrong. They can't tell you how you came up with that answer and what you did wrong. I do that on the game show. When I write these questions, I put something in the question, or I'll put the answers in a specific order, or I'll use a specific word in the answer that is specifically designed to trip you up, just like the state test will. And then I tell you, after we answer the question, what I did and what you did, and then how you can overcome that. So yesterday's game show, there was one question that I specifically put the answers in an order so that everyone would pick the first answer. It sounded right. The question, the answer, it sounds right. You pick it, you put it in the chat. It wasn't the right answer. The right answer was the fourth one. I stopped you on question 1 on purpose. I wrote it on purpose. Those that actually read the question and all 4 answers before making their decision, they're the ones that got it right. So the game show helps explain how tests are structured and the pitfalls that you might fall into, so you can learn how to answer questions properly. It's, in my opinion, better than just a practice test. Practice test is going to tell you whether you have the knowledge and can apply it. This goes a step further, which is why I pay for the program that allows me to do. That's not free, by the way. That practice test costs me money every time I'm on there. I have to pay for the program and the prizes. It costs me money to do that game show. I do it for you guys so that you can learn the content and how to test properly. So if you're really struggling on the reading and you haven't had a chance, go watch those game shows. They will help you. I promise. Good.
Yeah, and she does a really good job of explaining why the answer is the answer it is. Because sometimes you're like, well, but that sounds right. You know, that's what I would do. And,
Yep.
you know, but until you start learning how to be a CNA, this is a better choice because.
Right.
Oh, most of the answers are like directed to the nurse. Like I was like, I wouldn't know if I wasn't here or learning about, like, they would keep on telling me everything that's abnormal. You're telling the nurse the small changes. Like most of the questions, answers were reporting it to the nurse.
Yes.
I wouldn't think of it if I wasn't here.
Yeah, and a lot of people that are getting ready to take the CNA test, they think that they have to solve the problem.
Yeah.
And that's what the test is judging you on, right? They've got to know that you know your role. You're not going to be solving problems. It's not your role. So yeah, that's a really big part. But I will tell you, this trips people up. When you start watching the game show and you realize that everything gets reported to the nurse, if you know it, they've got to know it. You're reporting everything to the nurse. You start to just automatically pick that answer. It doesn't matter what the question is. You just start to automatically pick that answer. But if it's an emergency, report it to the nurse is not the right answer. Stay with the patient. That's right. Or address the emergency. So yeah,
we're watching yesterday, staying with the patient. I chose the wrong answer, but it was staying with the patient.
Stay with the patient. And I wrote that one specifically for that reason.
Yeah.
And the way that the question was phrased was designed to trip you up. So it's making sure that you know emergencies are different. Emergencies are handled different. If the patient is choking, we got to do something. We'll report it to the nurse after we've saved the patient. If they're having chest pain, right? We got to sit them up if they can't breathe. You know, we got to do something. Emergencies require action.
We just need to
And we
use the
just
call
call a
light.
nurse.
We need to use the call light, I guess.
Well, you're the one that answers the call light. See, so hitting the call light isn't going to help, right? Because CNAs,
You're gonna have to
you yell loud. Somebody get the nurse now. Emergency.
So you yell it out as you're trying to help.
Oh, absolutely. Absolutely. Yeah, we need somebody there that can take over. But don't just stand there and stare at the patient when they're choking to death and they can't breathe and go, "Yeah, I don't know what to do for you. Sorry." I don't know. And that happens. What's that?
You're like,
I'll be back. Yeah. Yeah, I'll be back. Yeah, let's not do that. So emergency, I always think ERA. Emergencies require action. Everything else, report it to the nurse. But emergencies require action. Okay?
Yes, I think the question yesterday was if the patient falls, what do you do?
Yeah.
Exactly. That was the question.
Yeah.
I was like, I need to like call somebody for help. I was like, I didn't pick up.
Yeah, 'cause it's
Option
like
like
you don't
stay
want
with
to
the
pick them
patient.
up and hurt. If they're hurt, you don't want to.
Well, the question was your patient falls and has no visible injuries. What do you do?
Yeah.
Do you get them up and continue care? Do you I'm trying to remember what
One of
the
them was reported to the nurse.
yeah, report it to the nurse.
Another one
Document. No, it was document. Yeah, document the fall. Stay with the patient and get them out of bed to continue care. And hold on, I'm trying to think of
I
the
think like don't care about it, like because there's no visible.
oh, notify the family. That was the fourth one. Notify the family. So your patient falls and has no visible injuries. Do you A, get them up and continue care? B, notify the family? C, stay with the patient? Or D, document the fall? Yeah, you stay with the patient. Yep. But a lot of people would get them up and continue care because the question says no visible injuries. The problem is that a broken hip isn't visible. A concussion isn't visible. They may have an injury that you aren't aware of because you aren't trained to assess.
Well, some of those answers are kind of what I would do. Like I would still stay with the patient, but I'll still document it and contact
But you
the
can
family.
only pick one on the test.
No, you CNAs don't contact the family, not your role. That's the nurse. And documenting doesn't do anything for the patient. So if you chose document, you're not helping the patient at all. Where's your focus? On you. Where should your focus be? On the patient. So documenting does not take care of the patient. Sure, you probably will have to fill out an incident report later, but that's not what the question is asking. The question, right. Yeah. Do you see how the test, it's not as cut and dry. It's not just asking you what color is the sky. And by the way, that's a trick question too. Yeah. Yeah. The sky, there is no color to the sky at night. There is no, it's stars, right? But if you go outside and you look up, what color is the sky? Well, it's blue. It's blue. Well, actually the sky isn't blue. What you're seeing is refracted light. The sky itself isn't blue. It's just the scattering of light. So that's a trick question, right? So if you're giving that question to a fifth grader, blue is the right answer. That's what they're learning at their level, right? The sky is blue. If you're giving that question to a science major in college, the answer is not blue. Same question, two different answers. Why? Different level of knowledge. Okay. So tests are written, guys. Trust me, I have extensive training in test writing, all of the psychology that goes into test writing. So test writing has to be done at the level that you're testing at. So that's why the questions are written in a certain way. All the rating that you're doing, I know it seems like a lot. I know it can get overwhelming, but that's all information you're going to need to be able to apply to the test at your level. Okay. Good.
Mhm.
All right, let's talk about feeding. Feeding is a skill that is different from the other skills that we do. It doesn't follow our normal rules. It's going to be different. And we're going to go over what rules we're going to break with feeding, what rules are going to be different, as we learn this skill. But there's no new principles to learn. We know to follow the care plan. We know to do our opening. We know to wear gloves if we need them. We're going to talk about gloves in a minute. We know that we have to have some sort of a barrier between the food and the table. We know not to hold anything against our uniform like a clothing protector. We know to do the closing. We know all that, right? There's nothing new there to learn. If you go to page 109, at the top of the page, this gives us our care plan. And then we have step-by-step instructions listed there that tells us how to do this skill. At the bottom of the page, you're going to see your supplies. So you need a towel, you need a hand wipe, you need a food tray, you need a pen, and a documentation form. Let's take a look at this care plan in detail. It says to feed the resident a snack who is unable to feed him or herself. So on the test, we're giving them a snack, which is a single serve pudding or applesauce cup. That's what they use for snacks for the test. Single serve pudding or applesauce cup. Now, if you remember earlier today, I told you that this skill is going to require some accommodation if you're the patient. So if you are the patient for this, and this is a live patient skill, if you look on the page before at the bottom, whoops, I'm sorry. On page 108 at the bottom, you can see it's live patient skill. So you might be a patient for this skill. If you are a patient, they're going to give you very specific instructions. First, they're going to tell you to slump or slouch when you sit in a chair. Slump or slouch. Yep. So just slump or slouch. Doesn't matter. And I'm going to tell you why in a minute. We're going to go back to this care plan in just a second, okay? But they're going to tell you to slump or slouch, and they're going to tell you to only take 4 bites and then no more. No matter what the CNA says, 4 bites and then you're done. Okay? So all you're doing for the test is taking 4 bites. You can drink if it's offered, not drink, whatever you want. I don't care about the drink, right? But for food, you're only going to take 4 bites and then say you're done. So you're going to get very specific information for this. Let's go back to the care plan. It says that we're feeding a patient a snack and you're only taking 4 bites. So you're not, even if you don't like pudding or applesauce, just try to choke down 4 bites, okay? It tells us the resident is sitting in a chair in an inappropriate position for eating. I don't care what your eyes tell you, okay? So you are kind of slumped over a little bit, right? So if you looked at her, if she was your patient, you probably wouldn't think she's in an inappropriate position for eating. I mean, every 12-year-old eats just like that, right? Yeah, she's up, she's fine. Now, if you walked in and the patient's like this, that would be different, okay? However, remember that this is a testing person that's playing our patient. And when I tell you to slump or slouch, I'm going to get exactly what you said. What does that mean? Slump or slouch. Just don't sit up straight. That's all they're going to tell you. So your idea of slouching and your idea of slouching might be 2 totally different things. Doesn't matter what your eyes tell you. What does our care plan say? They're not sitting up straight. So for the test, I don't care what your eyes say. You tell that patient to sit up. That's all you got to do is tell them, hey, can you sit up straight, please? All you've got to do. No matter what your eyes tell you. Because our care plan rules. Now, I'm going to tell you in a clinical setting, you're never going to have a care plan that tells you your patient's in an inappropriate position. You're supposed to look for that. Okay. But this care plan for the test is giving us that information because we don't know what your patient's actually going to do. So document the intake on a food and fluid intake form. So if you go to page 169 of your book, you can see a form there for food intake. And it has a section for whether it's a snack or a meal. What are we going to use, snack or meal? Why? That's what the care plan said. Now, we're only feeding 4 bites. We're going to talk about percentage in a minute, but it'll only be 25%. I can guarantee that. And fluid, it depends on what they drink. We're going to get to that, to percentages in just a few minutes. But this is your food and fluid intake form. So you can make copies of this to practice with if you want. All right, so we already know all of the principles that we need to know to do this skill. We know to follow the care plan. We know to do the opening. We know that to evaluate if we need gloves. We know to not hold the clothing protector against our uniform. And we know to do the closing. There's nothing new here. So let's look at skill-specific steps. For this skill, there are some changes to what we've learned. For this skill, we're not going to use a barrier in the traditional sense. We're not going to go grab a Chuck's and put it on the table because our food tray is our barrier. We are using one, but it's built in. The food tray is your barrier. This skill is the only one where we don't close the privacy curtain, and that's because eating is a social event. People gather in groups to eat. So if you close the curtain to isolate the patient, they're not going to eat as well. And that's a problem because if we don't eat, tomorrow we have less energy. And that means we're not going to eat as well. And the next day we're going to have less energy. And this causes a downward spiral, bless you, that is actually, there's a term for it, failure to thrive. So we want to encourage this patient to eat. We want to make it seem like we want to be there, like we're invested in their eating. Make sense? Part of that is not closing the privacy curtain. Whenever possible, we like our people to eat in groups. So we take people to a dining room to eat with other people. People that eat in their room generally don't tend to eat as much. And this, I found this fascinating. I'm a huge psychology nerd. I found this fascinating. During COVID, what happened in assisted living facilities and nursing homes is still being studied because during COVID, we shut down the facilities. Families weren't allowed to come in and visit. So we've got isolation. We've got isolation. And then further, we made every patient eat in their room. They weren't allowed to go to the dining room. We wouldn't let anybody gather together in groups. There were no activities. And there was a statistically significant higher death rate during COVID that was not related to COVID.
Yeah, because they're depressed and they're mentally.
Right, because of the isolation. Yeah, why am I here? Nobody's visiting me. And for patients that have dementia, they have no way of understanding why nobody's visiting.
Oh, I did read that some families who had the fortunateness to be like here in Florida where the weather was nice, if they had balconies or little patios, their families would come visit them outside the patio where they were sitting on the patio.
Right. Yeah. Yeah.
Look in the windows and-
Yeah. Yeah. And that was helpful, but not, it's
enough.
still, yeah, it wasn't enough. It was. And there were some facilities that still wouldn't even allow that. They became very militant about it. And again, I go back to help isn't help if it doesn't help. And I think that I think we learned some things from COVID. I really do. And I think that the need to keep the patients safe from the virus is very important. But I think the way we went about it needs a little bit of revision. Yeah, definitely needs some revision. I have some very specific thoughts on how to enforce isolation in a clinical setting. The biggest problem with it is that, yes, we kept family members out. Absolutely. I mean, that helped, right? It helped prevent the pathogens from being introduced into this setting. The problem is that caregivers were going in and out. caregivers were going to Publix and they were going to baseball games and they were out in the community and they were gathering at birthday parties that they weren't supposed to. Right.
And they were bringing COVID into the
That's
facility.
exactly it. Yep. So we
Even though the
forced,
facility was locked down, they still had COVID cases.
exactly. So the forced isolation was not effective. So we had a lot of detriments with very few benefits. And I think that we probably learned a few things about that. Okay. So don't close the privacy curtain. We don't want that isolation. We want people to be able to see other people and interact with them. Do not rely on a TV as your form of socialization when you're feeding a patient. In fact, TVs really should be off unless your patient has a specific show that they're watching. The socialization needs to come from us during feeding. So you actually, for the test, you're graded on having a conversation with the patient. So this is the one skill that we don't want to announce our steps. We're not going to say, I'm wringing the washcloth out, I'm putting soap on the washcloth. We're not going to do that. We're actually going to have a conversation. For the test, it doesn't have to be real. You can say they're playing bingo in the activity center later today and the jackpot's at like $2.10 and Betsy thinks she's going to win it. What do you think? She's got her lucky shirt on already. You know, I mean, you can play around and make something up. That's perfectly okay. They're playing a movie on the big screen in the theater later. Do you want to go? I've never seen Casablanca. I think it, you know, I'm going to go because I think it's pretty interesting. Whatever, just make something up. In the video, I actually talk about a football game. And if you're into sports, that's perfectly okay. If your patient is sports oriented, perfectly okay. But you do have to have a conversation. Part of that is you have to sit while you're having the conversation. If you stand over somebody and you're shoveling food in their mouth, they're going to feel rushed, but there's a power dynamic there. And the patient is going to feel inferior. Now, why is that important? It is. So this is actually the hardest skill to be a patient for. This skill is harder to be a patient for than Peri-Care. I'm not talking about during the test. I'm not talking about when we're practicing and playing around. I'm talking about for real. It is easier for a patient to have somebody do Peri-Care on them than to have somebody feed them. And there's something very psychological about this. And it's because eating is the first skill you become independent at. The very first skill that you control. You learn how to hold your bottle before you know what hunger is. You know how to pick up Cheerios and diced peaches off a high chair tray before you can even sit up. We prop you in that high chair. Eating is the first skill you master. And when you lose the ability to feed yourself, it affects you in a psychological way like no other skill. So if you've got somebody that's feeding you and you're already suffering this identity crisis and they're treating you like it's an imposition, like they're rushing you, like, you know, you don't matter, that's going to affect your eating. And unfortunately, when we feed people, they already don't eat much because they don't want to take up your time. So we've already got decreased intake, and then you add the psychological aspect on top of that, and they will stop eating. So pull up a seat, slow down, have a conversation, and treat them like this is your time to rest.
Wait, why are you having a conversation with the patient while they eating? What if they just want to eat? 'Cause I know I don't want to be talking while I'm eating.
Do you ever go? Yeah. Do you ever go out to eat? Where do you go? What's your favorite restaurant?
Longhorn.
Okay. So you walk into Longhorn on Friday night, right? And you're ready to eat. And do you go by yourself? Who do you go with? Okay. So you two walk into Longhorn. When you walk into Longhorn, is it dead silent? How weird would it be if you walked in and there's like 60 other people and it's completely silent? How weird is that?
Yeah.
Have you ever been to a school cafeteria?
Yeah.
The loudest place.
Yeah, absolutely. Absolutely. People talk while they eat. You don't talk with your mouth full. But when you and your mom go to Longhorn and you're sitting at the table across from each other and you have food in front of you, are you completely silent during that time?
Sometimes I don't be talking while I'm eating. I just want to enjoy my food.
I mean, he is in isolation already, so he wants somebody talking to him at some time.
Right. Yeah, absolutely. He's in
You don't see
isolation.
somebody
He
so
needs, yeah,
often.
he needs the conversation. Like he needs the social interaction.
Yeah. And yes, you may be enjoying your food, but you're probably, you may not be aware of it. You may not be consciously aware of it, but you're probably having a conversation. Something like, how was your day? Where are we going this weekend? What are you ordering? Hey, I really wanted to try that. How is it? Or, oh, I'm too full. I'm not going to have dessert tonight or whatever. You're having a conversation. You just probably aren't aware that you're having a conversation. Now, we're not having we're not always having like heartfelt spilling our deepest, darkest secrets at the table. I mean, it could just be something as simple as, wow, you know what I learned in class today? But you're probably having some sort of a conversation. And so is everybody around you, which is why restaurants are pretty loud, right? It's not just chewing. There's talking going on. We have to understand, and it's not something, that's why I have to talk about it, because this isn't something that we stop and think about quite often. We're not always aware of the conversations we're having while we're eating, because it's just kind of part of the whole experience. So you're much more likely to eat in silence at home.
Yeah.
If you're sitting around your own dining room table at home, which is why, if you notice, I asked, where do you go out to eat? I was very intentional at that. Because when you go out to eat and you're in a social setting, socialization increases. Yep. You're talking about what she's wearing and how he's acting, and there's other influences there. So we have to keep that in mind when we're feeding somebody in a clinical setting. If we're in a congregate dining room, there's probably going to be more socialization. If we're in their room, it's up to us to keep up that level of socialization. Make sense?
You're not going to be eating, so you're going to be fine having a conversation.
Right.
When the patient doesn't wear like anything on them, like, are you getting to that point?
We're getting there. All right. So we have to make sure the patient is sitting fully upright, and we're going to do that because our care plan says they're not. So for the test, it's just as simple as, can you please sit up straight? Just ask them. We're going to offer a hand wipe, and that's because most people wash their hands before they eat. It's part of the eating ritual. It stimulates appetite. But even though we're feeding them, they may bring their hand up to their mouth to wipe something away or push food in, and we don't want dirty hands up near a portal of entry. So we're going to offer them a hand wipe. Would you like to wash your hands? And a hand wipe will be on the top of your bedside table. You're going to offer them a clothing protector. They might want one. I need one. I need one now. Everything I eat, I wear. It's just gravity. I would say, yes, I'll take a clothing protector because I know I'm going to need it. My grandmother, if you offered her a clothing protector, oh no. She was prim and proper, and I am not a child. I do not need a bib. Get that thing away from me. So we're going to offer, would you like a clothing protector? We do not call it a bib. Bibs are for babies. We call it a clothing protector, and we're going to offer, would you like a clothing protector? Okay, so we offer a hand wipe, and we offer a clothing protector before we get started. Then we're going to pull up a chair. You want to sit where you can easily feed the patient. If you're sitting directly across from them, it's going to be hard. You're reaching over their food. And I don't like reaching over somebody's food. I just think that's a little gross. So I sit off to the side. Food is on the table. I'm on the side, and I'm feeding in that direction. But the test doesn't grade you on any of that. The checkpoint is sit. Sit. We're going to offer a drink before we feed them and every 2 or 3 bites. They may want a drink. Remember, this is another testing student. They probably have a dry mouth because they're stressed. They may not. Perfectly okay. Everybody has different eating preferences. Some people drink an entire cup of water before they eat. My aunt was like that. She used to be a model years and years and years and years ago. And she always had a large cup of water before she ate anything. And she swore it filled her up. Yeah, it doesn't work for me. I've tried it. It doesn't work for me now. But she would, that was part of her ritual, right? So for her, you would want to give her water before she ate. Now, some people don't drink it all while they're eating. They drink after they eat. Me, I have to have a drink while I'm eating because I don't swallow real well. I need that liquid to help, right? So everybody's a little bit different. We all have different eating idiosyncrasies. We don't stop to think about it, but we do. Same thing with eating itself. Some people eat all of one thing on their plate before they move to the next. Some people take a little bite of this and a little bite of that, and a little bite of this, and a little bite of that. Some people will mix their corn and mashed potatoes. Other people are like, don't let my foods even touch on that plate. We need to know a little bit about what your patients like, because if you are a mix the corn and mashed potatoes person and you're feeding somebody who is not, and you just mix that corn and mashed potatoes without even thinking about it, that patient isn't going to eat it. Okay?
Yeah.
We are their hands.
We're helping them.
We don't make their decisions. Good? Make sense? So ask, get to know your patients a little bit. So we're going to offer a drink before and every 2 to 3 bites. How many bites did I tell you that person's going to take? 4. So that's why they're taking 4, because the checkpoint is at least every 2 or 3 bites. So if we get to 4 bites and you didn't offer a drink, you're not getting that check mark. Okay.
So we gotta ensure that we're offering the drink before about 4 bites goes in.
Right. So before they eat and every 2 or 3 bites.
Okay.
Okay. We're going to feed slowly. Spoon should only be about half full. So we're only giving 4 bites and the spoon is only half full. So we're not feeding them very much. Okay. Not feeding them very much. We're going to have a conversation and it is graded. It is graded. A conversation is graded. This is the only skill where you are graded on having a conversation. It does not say recite steps. It says conversation. So make something up. We also want to encourage intake. So when they stop eating at 4, they're going to say, I'm done, I'm finished, no more, whatever they say. We want to encourage intake. And you really should do this at least 2 ways. I'm going to give you 3. But you really should do it about, you really should try to incorporate 2. 1 is polite. 2 means you care. That's the impression you're giving the patient. So the first thing I'm going to ask is, are you sure you don't want just 1 more bite? And I turn up the charm. It is really hard to resist me when I become charming. Okay. You sure you don't want just 1 more bite? Come on, for me, I don't want to get up yet. Come on, 1 more. And I can usually get somebody to take 1 more. Even if they're full, they're going to take 1 more because, they think they're doing me a favor. And they like me because I'm good at what I do. Right? If I'm like, do you want any more? I'm not going to get anybody to take anything, right? The second thing I'm going to ask is, do you want something else? Like if they didn't fit, if they only took 4 bites, half bites, chances are they didn't like what I offered. So we've all had those days where you make something, you take a bite, you're like, nope, not it. Not what I was looking for. Sounded good, but it's just not doing it, right? We've all had those days. Well, you get to go to your kitchen and make something else. This patient is stuck with whatever's in front of them. So I usually ask, can I get you something else from the kitchen? Maybe another meal, maybe another option. So the first thing I ask, you sure you don't want just one more bite? Second thing, can I get you something else from the kitchen? And the third thing that I will say before I leave that patient is, please let me know if you get hungry later. I've got food available on the unit and I'd be happy to give you something. That way they don't stay hungry. Okay. If you do those things, your patient feels cared about. It's not just shoving food in somebody's face. That's the difference between feeding and feeding with dignity. Good. Just like with mouth care and denture care, leave their mouth clean. We've talked about this. I don't know why this is a missed checkpoint. Leave their mouth clean. And then you're going to document. Now, we're going to talk about percentage here in a minute. But there's 2 lines for documentation. One is for the food that we gave them. The other is for the fluid that we offered them. These are 2 separate lines of documentation. So make sure that you address both of those. So here's our details. We want to sit while we're feeding. We're going to offer a hand wipe before and a clothing protector. We're going to offer a drink before, and every 2 to 3 bites, we're going to let them lead. We're going to feed slow. The spoon should only be half full, and no childlike feeding techniques. No planes, trains, or automobiles. I'm going to tell you, in a clinical setting, you will have patients you can play around with. I use a lot of humor in my nursing. I find that it's a great connector, a great humanizer. But during the test, we're not going to use any of that. We're going to keep it, where it needs to be. But I have had patients that I'll just do the choo-choo train just to get them to take a bite, just because they're being difficult eaters. All right, so let's talk about food percentages. In most settings, we document food intake using a quarter scale. 0 means they didn't touch anything. 25% means they picked at it. They ate a little bit, but not half. So 0 is refused. 25 is they ate a little. 50 is half, roughly half. 100% clean plate club. 75 is somewhere between 50 and 100. This is not scientific. We're not measuring anything. This is eyeballing. Okay. Quarter scale. So this demonstration kind of helps us with this particular activity. So if this is what we started with, a sandwich, some broccoli, and some Jell-O cubes, how much of the meal did they eat? If you look at the first graphic there, they took a bite of the sandwich, ate a bite of the broccoli, ate a couple bites of the Jell-O. Yeah, they picked at it, 25%. It's not, they didn't refuse it. It's not coming out the same way it went in, but that certainly isn't half. Now, if you look at the second one over here, they ate about half of the sandwich, about half of the broccoli, and a little bit of the Jell-O. What would you want to call that? Yeah, about half. Absolutely. What about this one down here? 75. Now, this one gets tricky, right? Because people get hung up on that broccoli stalk and the 2 pieces of Jell-O there. It is close enough to 100% that we can call it. Broccoli stalks don't count. They just don't. They just don't. So this is a judgment call. Close enough. Okay. Here's the thing about food percentages. On an individual meal basis, they have no bearing. They really don't. We're documenting them. But as the nurse, I'm going to look at the whole intake for the week. Okay, they're eating 75 to 100% of every meal all week long. Hey, that's good. I've got somebody with a good appetite that's not having any swallowing difficulties. Their digestion is running just fine. They're on the straight and narrow. They're good. I'm happy with that. Now, if I look at that same person and Monday, Tuesday, Wednesday, they were eating 75 to 100%, and then they dropped off and everything past that was all 25%. What does that tell me? Something's wrong. I have an opportunity for assessment. That's how we use meal intakes. They're able to flag that over a big picture, they tell us what's going on with that patient's appetite and digestion. So on an individual percent, you call that 100%, it's fine. It's not that technical. Okay.
There's a quick question on the side.
Yep. Are the food and intake of the water all documented on the same, like adding them together? No. So let me go back to this.
You did say legally after understood, so I just wanted to verify that it was addressed.
Okay. All right. Thank
I
you.
do believe she understands as well. Just wanted to verify.
Okay. So go ahead and take that. So Betty, this is the documentation form here. And you can see that there are 2 checkpoints. One of them says record the amount of residents' food intake within 25% of the nurse's measurement, and the record the amount of fluid within 25% of the nurse's measurement. So they're going to be documented under food and fluid on the intake form, and they're going to be 2 different checkpoints. Good question. All right. So now let's talk about intake and output, because that's a little bit different. So the quarter scale is just kind of an eyeball measurement, tells us big picture trends. This is scientific. This is technical. And this is used on a micro, not macro effect. So when we are, for the test, we're doing that quarter scale for fluid, right? 20, if they took a couple sips, 25% for fluid. But on the written test, you are going to have a question about intake conversions. So I've got to explain this. So what this means is, in America, we measure everything in ounces. But in medical, we measure everything in cc's. That means that we have to convert. So if you look at that water bottle in front of you, it probably says 15.9 ounces on the measurement. Okay, sorry, 16.9 ounces. Now, if you look at right next to it in parentheses, there should be 500 mLs. All right. So when you have a pre-packaged food item, it will have both the empirical measurement ounces, but it will also have the metric measurement or mLs. mLs, and cc's, same thing, 2 different names. Remember, in healthcare, everything has 2 names. So cc's equals mLs, same thing. There's a scientific difference, but we're not going to get into that. So for our purposes, cc's and mLs, same thing. It's what we're going to use in healthcare. Now, if you have a milk carton, it's going to tell you how many mLs, 240 mLs. If you have a juice container that's prepackaged, it'll tell you 4 ounces, 120 mLs. It tells you right on the package. But most of healthcare doesn't come prepackaged. Most of the things that your patients are going to drink are things like coffee and water. Things that don't come in a package. And in that case, we are going to have to do the conversion. So you can have a water glass or a juice glass when you go to work somewhere, and you can have a coffee cup, and you need to know how many ounces those 2 things are so we can do the conversion. So in most cases, water cups are 8 ounces. Coffee cups are 6 ounces, or, whatever your whatever size your facility uses. That's going to be something you're going to be learning in orientation. Wherever you go to work, you're going to have an orientation period. This is something they're going to cover, because this is something we're going to have to document. How many cups of coffee did the patient drink today? They drank 3 cups of coffee. Each cup is 6 ounces. So how many cc's is that? Because we're going to have to document that if our patient's on intake and output. Make sense? Good. So the way that we convert is every ounce is worth 30 cc's. So if we have a 6 ounce cup of coffee, 6 times 30 is 180. So that coffee cup isn't 6 ounces, it's 180 cc's. That water glass is 8 ounces. 8 times 30 is 240. That's not an 8-ounce glass. It's 240 mLs or cc's. Good? Make sense? You will have to do a conversion on the state exam, or you're going to have to calculate total intake for the shift. It's just addition. So if you look at page 106, I have an activity here for you. It has a couple of activities on estimating meal percentages. But if you look at the bottom here, right here, toward the bottom of the second column, we have a cup, a carton, and another cup. The first one is 6 ounces of juice. How many cc's is that going to be? 180. So we would write 180 in that spot. Now, the milk carton actually tells us how many cc's. So how many cc's are in that milk, or mLs are in that milk carton? 240. So write 240 there. And then we got 12 ounces of coffee. That's a big old coffee cup. I could use that today. So 12 ounces would be how many cc's? Not 3,000. You're close. Drop a 0. 360. 360. So then, if we needed to get the total intake per shift for this patient, we would add 180 plus 240 plus 360 together. Anybody know what that might be? A little bit more. Add another 100. You're close. 780. 780. Yep. Yep. Okay. If you add the last two together, it's 600 and then the 180. Yeah, just forgot to carry the 1. That's all. So for the test, you are going to have a math problem. It will either be converting ounces to cc's or adding up several ml or cc intake for the shift. Okay, but you will have some type of math problem. Now, if you go to page 132, I want to talk about medical abbreviations briefly. This is a list of medical abbreviations I put in this book for you. I would probably study these, especially the ones that are highlighted. I would learn these. But the one that I've got the red arrow pointing to about 3/4 of the way down, it says NPO. NPO means nothing by mouth. And I know that your little English brains are trying to make sense of that. How in the world does NPO mean nothing by mouth? Don't try to make sense of it in English because it's not. NPO is abbreviated Latin. And it means, if we translate it to English, nothing by mouth. That's something that you need to know. The other ones that are highlighted are also things that you need to know. Not likely to show up on the test, but you will use them quite routinely in a clinical setting. But I want to go to the ones at the top. QD, QOD, Q2H, QHS, all of those things. Again, this is abbreviated Latin. QD would mean every day because Q stands for quaque, which means every. My Latin's a little bit rusty, so I may have pronounced that wrong, but it means every. QOD would be every other day. Q2H is every 2 hours. Q4H is every 4 hours. QHS is how they say bedtime or insomnia or hour of sleep. So QHS would be bedtime. Now, BID and TID, again, are abbreviated Latin. B stands for bi. How many wheels are on a bicycle? 2. So BID means twice a day. TID, how many wheels are on a tricycle? T is for tri, which means 3 or 3 times a day. So that's medical abbreviations 101. They're not going to give you a question on the state exam that says, what does QHS mean? They won't ask you that. But they may say that your patient or you are assigned to do mouth care on a patient QHS. How often are you going to provide mouth care on this patient, right? And you need to know what that QHS means. So they work in vocabulary into the question itself. It's not just a what is type of question. All right, so page 169, again, we went over this, has that documentation form, so you can make copies of that and use it in your practice. Page 107 has a whole lesson on intake and output. You probably want to read this. I went over some of it in class, but this lesson specifically, there are a few things that I did not go over that you're probably going to want to read this page and answer the questions at the bottom to make sure that you have a good understanding. So now that we know all of the steps involved in feeding a resident, let's apply them to our checklist. Checklist isn't too bad on this one, actually. It's not very long. We're going to follow that care plan. We're going to do our opening. We're going to evaluate if we need gloves. I'm going to stop there for 1 second. Time out. Please do not use gloves when you feed a patient unless there is a reason to use gloves. Gloves give off an odor, particularly latex gloves. And that odor is a known appetite suppressant. So unless your patient is drooling and unless you know that you're going to be in close proximity to, body fluids, you don't need gloves for this skill. You're going to wash your hands before, you're going to wash your hands after, and you're on the other end of a spoon. Okay? You're not physically handling their body fluids. Now, if you do need gloves, wear them if the care plan calls for it. Or if your patient is drooling in some way and you need gloves. But for a routine feeding, again, it creates that layer of separation that's further going to isolate that patient. All right, linen rules apply. Remember, we're going to get our clothing protector for our patients, so don't hold it against your uniform. Don't throw it on the floor at the end. Here's your skill-specific steps that we've talked about. We're going to make sure a patient's sitting up. We're going to offer a hand wipe and clothing protector. We're going to sit while we feed them. We offer a drink before and every 2 to 3 bites. We're going to offer encouragement. We'll feed slow, spoon only half full. Give them time to chew and swallow. Have a conversation. Encourage the patient to eat. Leave the area around the mouth clean. And we're going to document. And then we'll do our closing. It's not a hard skill. It really isn't. Remember that this care plan is just for this person. So let's go ahead and take a look at the video. Now, I think they give you 9 minutes to do this. The video only takes, I think, 4. So don't rush. You've got all the time you need to do this. Don't rush, but make sure that you're being accommodating to your patient.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. Could I ask you to sit up straight before we get started, please?
How are you?
I'm good.
Fantastic. Would you like to eat a snack?
Yes, that'd be lovely.
Okay, I'd be happy to help you with that. Let me go wash my hands, get my supplies, and I'll be right back. Okay, Mr. Jones, I'll give you a hand wipe so you can clean your hands before we feed you. Okay, would you like to take the hand wipe?
Yes, please. Thank you.
And go ahead and clean your hands. Thank you very much. I'll dispose of this in the trash. And would you like a clothing protector?
Yes, please.
I'm going to go get one for you.
Okay, Mr. Jones, I'm going to take this clothing protector and put it over your chest. This will just protect your clothing while I feed you. And I'm going to pull up a chair. How are you doing today?
Very good.
Wonderful. Would you like a sip of water?
Yes, please.
Okay. And we have cinnamon applesauce. How does that sound?
Great.
Wonderful. Here we go. We're going to fill the spoon less than half full. And do you enjoy sports?
Yes.
What sport do you like?
Football.
Oh, I do too. Did you watch the big game
I
yesterday?
was so happy my team won.
Oh, it was such a great game. I couldn't believe in that last quarter what happened. Another bite?
Yes, please.
There you go. Would you like a drink?
Yes, please.
Okay. Good?
Yes.
All right. Yeah, my favorite team doesn't win very often. Usually when I'm watching, they're guaranteed to lose.
Usually for me as well.
Would you like another bite?
No, thank you.
Are you sure?
Yes.
Okay. Can I get you something else from the kitchen?
No, thank you.
Okay, if you get hungry later, please let me know.
I will.
Okay. All right, I'm just going to take this clothing protector off. And we'll clean your face. I'm going to put this in dirty linen. I'm going to dispose of all the disposables. And we'll return the tray to the bedside table. Just going to move this to the side. And are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. There's your call light. If you need anything at all, just hit that red button. We'll be happy to come help. I'm going to go wash my hands and document. After washing my hands, I'll document the amount of food the patient ate and the amount of fluid that they drank. Once I'm done documenting, I'm going to go wash my hands one final time. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, any questions?
No, if they were eating something sticky or whatever, could we use the hand wipe to?
Sure. Yeah. Yep. Please be aware that sometimes your patients have some unusual eating idiosyncrasies. Probably the most unusual one that I saw when I was working out in the field, I was working in a nursing home, and we had a little old lady. She was, this is 35 years ago, but she was a true Southern belle. And anytime we would eat, serve things that she had to take a bite out of, she wouldn't eat it. So like pizza or hot dogs or hamburgers or sandwiches, she would not touch it. She wouldn't eat it. And her daughter came to visit, and I asked, I've noticed this. And she says, oh yeah. When she was growing up, young ladies did not take a bite out of food. It had to be cut up and presented on a fork. Yeah. And I had no idea that that was even a thing. I mean, I didn't grow up in that society. How would I know? So if you notice that your patient is, has some trends, or you notice, something, ask the family. A lot of times you'll get some input that it'll expand your cultural horizons as well.
Can they use like something different? Like hand wipe? Can they use like hand sanitizer?
Not for the test.
Okay.
Not for the test. In a clinical setting, you will go by your policies and procedures, whatever your facility requires. Okay. I can't answer that yes or no because I don't know where you're going to end up working. You got to go by your facility's policy and procedure. Okay. I don't like using hand sanitizer on patients, particularly older patients, because it dries the skin and they already have a problem with dry skin. And I don't want to further irritate that skin and cause skin rashes or cracks to form, which are body openings. So in a clinical setting, if I'm writing the care plan and it's an older individual with decreased oil production, no, they're not going to use hand sanitizer. We'll use very mild wipes. Okay. So there's a lot of things that we have to take into consideration. It's not just cut and dried, one size fits all, right? Whole lot of things we have to think about. Yeah. Hand sanitizer is fine for you. You've got young skin. All right, so let's get into providing Peri-Care to an incontinent resident. So this is page 152. Like partial bed bath, this is actually a lot like partial bed bath. Like partial bed bath, there are a lot of principles involved in this one. Every principle except for shoe rules is going to be here. They're all spelled out for us here. Down here is our test specific information. So somebody with your level of experience should be able to get this done in 17 minutes or less. Remember, Peri-Care was 19 minutes. This is 17 minutes. So it's a super long skill. This is going to be a mannequin skill, thankfully. This mannequin's going to be in the bed. Documentation is not required for this particular skill. If you go to page 153, at the top we have our care plan. We have some step-by-step instructions. It's going to be continued on page 154 because there's a lot of steps. Down here are your supplies. And yes, you do need to learn your supplies. But I want to bring your attention. We have our barrier. We have our privacy blanket. But then we have 2 under pads, not just one. This is the first time that we're going to use multiples of under pads. Bath basin, soap, 1 towel, 4 washcloths, and some gloves. So here's our care plan. It tells us the female resident has been incontinent of urine and needs perinatal care. The pad under the resident is wet, but the hospital gown and bedding is dry. That's a miracle. It never happens. Take the gift they give you for the test. In a clinical setting, if your patient is wet, so is their gown. We're going to have to clean them and change the gown. Don't leave a patient in a wet gown or on wet sheets. That's just uncomfortable. So we know all of these. Let's learn this. We know all of those. So let's focus our attention on the steps specific to this skill. So before we can learn about how to care for an incontinent patient, we have to learn what incontinence actually is. What area is affected? What does this mean? So this is a normally functioning urinary system. We have 2 kidneys. Those kidneys filter blood 24 hours a day. This process never, ever, ever stops. Out of that blood, it's going to pull out impurities, waste products, and it forms urine with those waste products. That urine goes down 2 tubes called ureters into the bladder. Down here at the base of the bladder is a valve. That valve stays shut, holding the urine in the bladder. This is why you can go about your business. When we go to the bathroom, that valve opens, the urine comes out until it's empty, and then the valve closes up again. So this valve is generally kept in a closed state unless you're actively emptying the bladder. Everybody got that? When somebody is incontinent, that system still works the same. We still have 2 kidneys. Those kidneys still filter blood and remove waste products. Those waste products still go down tubes in the form of urine into the bladder. What is broken here is the valve. Everything else is working fine, but those drips of urine, instead of being held in the bladder, just keep going. They go out. Remember that our kidneys produce urine 24 hours a day. So if we have a patient who is incontinent of urine, that means that that patient is going to be wet all the time. Drip, 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 drip. Make sense? Okay, if a CNA, if I have a patient and a CNA says, yeah, I checked on that patient, they're dry, they don't need to be changed, I know that that CNA is lying. How do I know that CNA is lying? Because the kidneys work 24 hours a day. If I have an incontinent patient laying there that's dry, they're not incontinent. They are not incontinent. Do you understand the difference there? Okay, so when a patient is incontinent, we're going to have to clean and change them every 2 hours around the clock. Every 2 hours around the clock. And the reason for that is that adults are not like babies. With babies, you can put a diaper on a baby, put them to bed, let them sleep all night, wake them up, and they still have skin on their little tushes. It does not work with adults. That's because as adults, our urine is much more acidic. The acidity of the urine is going to be based on the foods that we eat. Babies eat breast milk, rice cereal, plums, applesauce. Yeah, very mild, neutral, non-acidic food. So their urine is not acidic. Adults, totally different. Adults have very acidic urine. And you keep that urine right up next to the skin for a long period of time, and that acid is going to eat into the skin. So with adults, we need to make sure that we're cleaning and changing every 2 hours around the clock. We don't call these things diapers. We call them adult briefs. Now, we do have our patients wear them when they're out of bed because that's a dignity issue. Nobody wants to wet themselves in public. So adult briefs are waterproof. They're going to hold the urine, keep it from getting on the clothing, preserve dignity. We still have to clean and change them every 2 hours because we're holding that urine right up next to the skin and it's acidic. So we're still going to clean and change them every 2 hours. But if they're out of bed, an adult brief is indicated. However, this is not a good solution because it's holding urine right against the skin and it's blocking out light. It's holding in body heat. So we've got warm, dark, moist. Is that a good environment? So in bed, there's a better way. If our patient is in bed and our care plan calls for it, we're going to leave our patient open to air. No adult brief. They're no undergarments. They're laying on a pad. That way, as the urine comes out, remember, drip, drip, drip constantly. As that urine comes out, it's going to spread along the pad and it's not held up against the skin. It's not light and air circulating, so it's not warm, dark, moist. When our patient has sensitive skin, this is a better option when they're in bed. But let's think about that pad for just a second. Yes.
And I don't know about this, but do we have protections like diaper cream that you would use on a baby? Do they have that for adults if they do have sensitive skin?
Yes, there's vitamin A and D, there's zinc oxide, there are some solutions for that. Skin prep is another one. We would go by our care plan for that patient. Right. They may have a cream, yes. The problem is that cream is going to hold moisture as well. And in small doses on occasion. So, for instance, with babies, we shouldn't be using diaper cream with every single change.
Yeah, I mean, I remember with my kids, I just put cream on them if they were having an upset tummy.
Right.
Sometimes at night if they, you know.
Yes. So when it's needed, right? Same thing with adults. We would use that cream when it's needed, but not as a general everyday thing. Yep. Yes. Yes. Yep. I remember being a very young mom and the doctor said to leave my child open to air because he had a horrible rash. And I'm like, no undergarments? Are you nuts?
Stay off the carpet.
Yeah, yeah. Are you nuts? And it wasn't until I got a little bit older and understood the mechanics involved that, yeah, that's very sound advice. Very sound. So Ava asks, out of the 22 skills, how many are we tested on? You will be assigned to perform 3 clinical skills for the exam. And that's if you're testing with Prometric. If you're testing with other states, it could be 5 depending. Now you're being graded on 5 skills. You're being graded on the 3 that you have to demonstrate, as well as hand washing and indirect care. Those are going to be graded, hand washing and indirect care are graded separately. But you're going to be asked to perform 3 skills. If you have our skills book, Jake, put the skills book in the comment, please.
So they don't tell you what skills are doing, they just pick them for you?
Well, you have like
By
that,
computer.
it's the computer picks. them
Right.
out.
The computer picks them. These are the skill sets. This is located on page 25 of our skills book if you have it. Yep. All of them are located on page 25, but you have 3 skills. One is an ADL skill, one is a mobility skill, and one is a documentation skill. So you will do these 3 skills. They are picked by the computer before you ever get there. So no, you won't have advance notice. You won't have, nobody's going to tell you beforehand. And that's because in a clinical setting, when you remember, this is all about you being ready to work. That's what the test is about. You are ready to go to work as a CNA if you pass the test. So nobody's going to call you up the night before at work and say, you are going to have these patients tomorrow and you're going to need to do a partial bed bath and Peri-Care, and you're going to have to feed somebody. And nobody's going to do that. Nobody's going to tell you ahead of time what skills you're going to have to do. By taking the test, you're saying you're ready to work, right? And by working, that means that I know how to do all of these skills because I'm going to have to do them all when I go to work. Does that make sense? So they don't tell you in advance. Why would they? Right? So you have to know all of them. Because you will. I mean, the whole purpose of the test is to be able to go to work. If you're not ready for the test, are you ready for work? Right. You're not ready to work. You're not ready. So when you're practicing, I want you to keep that in mind. You're not practicing for the test. What are you practicing for? Work. Yeah. Good. Let's talk about the pad, though. The pad is wet. It's interacting with room temperature. What do we know about room temperature? It always wins. It cools everything down to room temperature. So that pad is wet and cold. How does that feel to the patient? Oh, ick. If you were laying on a cold, wet pad, what would you want done? Yeah, change it, like now. So the first thing that we're going to do here is change the pad. And we do that, clean rolls toward me, dirty rolls away. So we already know how to do this. It's just a smaller version of the sheet. Okay, so let's get that patient comfortable first. Then we're going to get ready to wash. We're going to use that same leaves method that we learned with partial bed bath. We're going to use 5 leaves. This is the genital area. So we're going to wring out our washcloth and apply soap to all 5 leaves. So that means if I have my washcloth here and I've wrung it out really well, I'm going to put soap on this leaf, fold it, this leaf, fold it, this leaf, fold it, this leaf, fold it, and the back. Okay. Were you here for the leaves method?
Was it on Monday?
Yeah.
No, I thought it was no class. Because it was a holiday. I didn't know it was a class.
Oh, yeah, no.
Oh yeah, they didn't have the bus, and I
I
had
have
to
to
like.
didn't show because they thought we weren't
Oh.
supposed to come.
Yeah, no, if I don't have class, I will tell you there's no class on whatever day. Yeah, we don't take holidays off because I'm trying to get you ready for work. Not and in healthcare we work holidays. So, yeah, I don't take holidays off. I haven't had a holiday off in years. All right. So we have our patient laying on a wet pad that's cold. So we're going to change that chucks first. Clean rolls toward me. So I'm going to get the clean one rolled toward me, ready to go. Dirty rolls away. So I roll the dirty one toward the patient, tuck it up under their hips, and unroll the clean one, tuck it under the dirty, go around to the other side of the bed, repeat the process, just like we did with occupied bed. Are you starting to see that this is just a repeat of everything we've learned? All right. When we wash, we have our washcloth. It has soap on it. When we wash from top to bottom and then move away. Do not go top and then back up. We start at the top, we go down, and we move away and fold that leaf over. The second stroke goes down the outside, top to bottom. Fold that over. The third leaf goes down the other outside, top to bottom. Move away, fold that over. The fourth leaf is going to go right here. Between the leg and the groin is that crease. So we're going to clean top to bottom, down that crease, fold it over. And on the back, we're going to clean top to bottom, down that crease. So this is middle, side, side, skin fold, skin fold. We go from the middle out using a different leaf for each stroke and always top to bottom.
Do we do all of the washing first and do the rinsing at the end?
Yes.
Okay.
So right now we're washing 1, 2, 3, 4, 5. Set that aside. Wring out our rinsing washcloth. Rinse 1, fold, 2, fold, 3, fold, 4, fold, 5 fold. Set that aside and then dry top to bottom. Okay, so we're going to dry top to bottom. We never, ever, ever move back up. Ever. So inner labia down the middle, outside, outside, skin fold, skin fold. And then never move back up. Once we get it washed, rinsed, and dried, we scoot the patient toward us, roll them up on their side using scoot and roll. So the patient's in the middle of the bed. And then we wash the back side. So I'm going to take washcloth number 3, wring it out. This time I'm going to soak 4 corners. 1, fold, 2, fold, 3, fold, 4. And I'm going to start at the anal opening. And I'm going to wipe up the center crease. We'll fold that over. Now I'm going to wash one cheek. Fold that over. Wash the other cheek from the anal opening up. Fold that over. And then once more up the middle because it kind of like runs like a riverbed. It's where all of your urine is going to be. So middle, side, side, middle. Using a different leaf for each stroke. Whatever we wash, we rinse. Whatever we rinse, we dry. And then we're going to change that chucks one more time because now we've got a clean butt. We want it on a clean pad. We changed it first for patient comfort, but we've got a dirty butt laying on it. So at the end, we want to change it again. Yes, we're going to use a privacy blanket for this. Yes. Yes. That way we're only exposing the areas that we're actively working on at that moment. Good? So we know all of our steps for this. Let's put them together to get all of our check marks. Now, this is a really big checklist. Look at all of those steps, but you already know most of these. So if we look at this, we're going to do our, follow our care plan, do our opening. We're definitely going to wear gloves for this and take them off properly. We're going to use a barrier on our table so that we're not putting dirty rags directly on the table, definitely not on the floor. Nothing goes on the floor. We're going to use a privacy blanket to keep our patient covered while we do this, following our linen rules. Don't hold them against you. Don't put them directly on the table. Don't put them on the floor. Patient has to be in the middle of the bed at all times. Washing rules are going to apply, right? So we get water, we check it, they check it. Whatever we wash, we rinse. Whatever we rinse, we dry. We know these rules. We're going to clean our basin the way we clean all basins all the time. And these are your test specific steps. There's not many, right? There's not much that specifically has to do with Peri-Care for this one. Most of everything that we're graded on is stuff we already know. And then we'll do our closing. And if we've done it right, we're going to get all of those check marks and pass the skill with 100. This care plan is only for this patient. This one may have a different one. This one will have a different one. This one will have a different one. I do have male Peri-Care in your book on page, where are we? 155 probably. Is it? Okay, 154. Thank you. So 154 is going to tell you how to perform male Peri-Care. It is very, very similar to female Peri-Care. Yes, it is. It is. So any questions on Peri-Care? I'm going to show you the video, and then the rest of the class will be practice. You should have about 15 to 20 minutes of practice today. You'll have more on Monday. No, go ahead. You're good. You're good. Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to perform Peri-Care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. After washing my hands, I'll get my clean supplies. We're going to place the supplies on an overbed table, and we'll start with a barrier on the table, making sure that the absorbent side is facing up to catch any water spills. This gives us a clean place to put our clean supplies. For this skill, we're going to need 2 chucks. We'll need a towel, 4 washcloths, 1, 2, 3, 4, and a privacy blanket. We'll go to the patient area. And now I'm going to get a basin and soap. We'll place this on the overbed table. And I need a set of gloves. Now I'll go fill the basin. Miss Jones, I'm going to go get some water. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about a quarter of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. I'm going to set this on the barrier. And this is a privacy blanket. This is going to keep you warm and protect your privacy while we do this skill. I'm just going to stretch it out over your sheet. And then I'll pull the sheet down underneath the privacy blanket. And we're going to pull the sheet down to about your knees. Now, I'm going to prepare my chucks. I'll unfold them, hold them up lengthwise, and I'm going to roll it toward me. Clean rolls toward me. All the way to the end. I'll put this on the barrier and do the same with the second. I'm going to open it up. Hold it up lengthwise with the absorbent side facing me.
and roll it all the way to the end. Clean rolls toward me. We'll set that on the barrier as well. Now I can put my gloves on. I'm going to place the washcloth in the basin to warm. I'll take one of the chucks that's rolled. I'm going to lay it up next to the patient under the soiled chucks. And Miss Jones, if I can have you scoot toward me, please. And we're going to roll up on your right side so I can change the chucks under you. I'll help you roll. Okay, now that you're on your side, I'm going to take the soiled chucks and roll it in. Clean rolls toward me, dirty rolls away. I want to roll it so that the absorbent side is on the inside and the waterproof side is facing up. I'm only going to touch the waterproof side, and I'm going to tuck it underneath the patient's hip. I'll unroll the clean chucks and tuck it underneath the patient's bottom area, under the dirty. Okay, Miss Jones, come on back. Thank you. And if you can scoot to the middle of the bed. Thank you. I'm going to go around to the other side. Go ahead and scoot toward me. Thank you. And roll up on your left side. 1, 2, 3. And I will remove that chucks, the soiled one, and smooth out the clean. We'll fold this up and we're going to throw this directly into the trash can. Okay, Ms. Jones, can you scoot back to the center of the bed, please? Thank you. I'm going to expose you now. I'll make this as brief as possible. Please let me know if you're uncomfortable in any way. I'm going to roll the gown inside the privacy blanket, and this will expose the peri area. And then I'm going to use a towel over the upper thighs to keep all of that area dry. Now we're ready to clean. I'll take the first washcloth, wring it out, and soap 5 corners. We're going to use the leaves method, meaning the free ends are at the top of the diamond shape. I'll spray the first leaf, fold it over, spray the second leaf, fold it over, spray the third leaf, fold it over, spray the fourth leaf, fold it over, and the back. I'll set that aside. Now I'm going to clean the peri area. I'll hold the washcloth in my hand in a diamond shape, tucking in the 2 side corners, making sure I have control over the leaves and they're at the top so that we can minimize cross-contamination. Okay, Ms. Jones, I'm going to start cleaning you now. I have to hold you open just a little bit, but let me know if it gets uncomfortable. So I'll take the heel of my hand at the top of the peri area, retract slightly, and spread her open a little bit. And I'm going to clean right down the inside middle, top to bottom, one direction only. Once I reach the bottom, we'll move away and fold that leaf over. I'm going to clean the outside peri area, top to bottom. Fold that leaf over. The other side, top to bottom, making sure I don't ever move back up. Fold that leaf over. The fourth leaf will go right down that skin fold, the crease between the thigh and the groin. We'll fold that over, and then we'll clean this skin fold, top to bottom, and we'll set that aside. Whatever we wash, we rinse. So I'll wring out my washcloth using that same leaves method, tucking in the 2 side corners. I'm going to retract the labia and clean top to bottom. Down the center, fold that leaf over. The second leaf will clean the outside of the peri area, top to bottom. And then we're going to fold that leaf over. The third leaf will clean the outside of the peri area on this side, top to bottom. I'll fold that leaf over. The fourth leaf will clean the crease, top to bottom. I'll fold that leaf over, and then we're going to clean this crease, top to bottom. And now we'll dry. Okay, Miss Jones, I'm just going to unroll your privacy blanket, putting the gown back over your legs, and I'm going to ask you to scoot toward me and roll you on your side so I can clean your backside. 1, 2, 3, and we're going to roll up. 1, 2, 3. We'll expose your backside, and the evaluator will hold the mannequin in place for this process. So now I can clean the backside. I'm going to wring the washcloth out. And this time, we're going to soap 4 leaves. So 1, we'll fold that over. 2, fold that over. 3, fold that over. 4, set the soap aside. I'm going to start at the anal opening and move up the crease. Just like that. We'll fold that leaf over. I'm going to clean 1 buttocks. We're going to fold that leaf over, clean the other buttocks. We'll fold that leaf over and then once more up the crease. We'll set this washcloth aside. Whatever we wash, we rinse. So I'll wring that washcloth out really well. I'm going to hold it in that leaves shape. I'm going to rinse right up the center crease. Fold that leaf over. We'll rinse 1 buttocks. Fold that leaf over. Rinse the other buttocks. Fold that leaf over and then once more up the center crease. Now we'll dry those areas. So starting at the anal opening, we'll dry all of those areas. We'll set that aside. Now I'm going to take the new chucks, place it under the one that's on the bed, and we're going to roll this one toward the patient and tuck it under her hip, and unroll the new one and tuck it under the soil. Okay, Miss Jones, come on back onto your back, please. Thank you, and then scoot to the middle, please. And I'm going to go around and remove that soiled chucks. Go ahead and scoot toward me. And then we're going to roll up on your side, 1, 2, 3. So I'll remove that soiled chucks and smooth out the new one. Come on back onto your back and then scoot to the middle of the bed, please. Thank you. This will be thrown away. Okay, Miss Jones, you're covered. You're in the center of the bed. I'm going to go put your dirty linens away and clean the basin. I'll be right back. These items will go in dirty linen hamper. And I'll clean the basin the same way we clean all basins. We're going to dispose of the water into the sink. Rinse the basin. Dispose of the rinse water into the sink. Set it down. Disinfect it per facility policy. Use a paper towel to pick it up. Paper towel to dry the inside. Throw that away. Paper towel to dry the outside. Throw that away. And 1 for the drawer. On the way, we'll pick up the soap. Place it in the basin. Use the paper towel to open the middle drawer. Pick up the lotion and put it in the basin. And then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. We'll dispose of the barrier that's on the table. And then remove my gloves. Okay, Miss Jones, I'm going to pull your privacy blanket up and put your sheet back in place. We'll make sure that the patient is covered and that we roll the privacy blanket up in a ball as we remove it from the patient. I want to adjust the sheet for neatness and appearance. And I'm going to go place this in dirty linen. Okay, Miss Jones, are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine? No? Okay, your environment is clean. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. Your bed is in the low position. I'm going to open your privacy curtain and go wash my hands. We'll return this table to storage before we go, leaving our area clean. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Okay, any questions on that one? It should look pretty easy to you. I mean, once you get over what you're washing, it should look pretty easy to you because it's all stuff that we've already done with partial bed bath. We're just washing a different body part. All right. So the practice kit has everything that you need in it to practice the skills that we've gone over today. It has the gait belt. It has the wash basin. It has chucks. It has gloves. Everything that you need to be able to practice. If you're not practicing here, make sure you're practicing somewhere. Over the weekend, you're going to read chapters 8 and 9. 8 is on nutrition. 9 is on rehabilitation. Both of those are going to be very important to you. So read them and take the tests. Make sure that you are reading the after class wrap up emails. And Jake has already passed out your review sheet for today. Those of you that are joining us virtually, those review sheets are available on flcnatraining.com. You can see them next to the replays for each class that we have going on. So class 1 worksheet is with class 1 replay. And hopefully that will help you put into practice what you're learning in class. All right. So if there's no questions, I'm going to go ahead and sign off of online. Thank you guys so much for joining us. We will be back in class on Monday for our last week of classes. So Monday, we're going to have our final 3 skills. That's it. That's all we got left to do is 3 skills. We've covered everything else. Wednesday is going to be graduation, but you definitely want to tune in for that because I'm going to give you some secrets on how to ace your interview. Specifically how to answer that question. Tell me a little bit about yourself. There's a formula you can use to craft your own statement that's relevant to you that will automatically ace every interview that you go to. So hope to see you next week. Until next time, happy caregiving. Bye.